حياكم الله في مستشفى الموسى التخصصي البرج الشمالي. صرح طبي معماري جديد في الأحساء الانتماء إليه. حبيت أخذكم اليوم جولة سريعة نستعرض فيها بعض الإمكانيات والمرافق المتوفرة فيه. التصميم الداخلي أول ما تلاحظ العين، حرصنا يكون التصميم مريح نفسياً للمراجعين والزوار، والمبنى بالكامل مصمم حسب مواصفات ليد للمباني الصديقة للبيئة، مثل النباتات الداخلية والألوان المريحة للعين واللوحات الفنية المستخدمة. يضم البرج 60 عيادة تشكل عدة مراكز تميز، منها مركز العظام ومركز القلب ومركز العلوم العصبية، ومركز متكامل لعلاج الأورام بأحدث وسائل التشخيص والعلاج، بالإضافة إلى برامج طبية متكاملة مثل برامج إدارة الجلطات الدماغية. احنا الآن متواجدين في المختبر الطبي في المستشفى اللي يعمل بشكل آلي بدون أي تدخل بشري، بحيث يضمن الحصول على النتائج بدقة وسرعة عالية. والآن سلامتكم على رأس أولوياتنا، جهزنا وحدة التعقيم المركزي بأحدث المعدات اللي تقوم بتعقيم الأدوات الجراحية على 3 مراحل: تطهير، تعقيم، ومن ثم التخزين. عندنا في مستشفى الموسى 14 غرفة عمليات رقمية مزودة بأحدث الأجهزة الطبية. هذه الأجهزة تساعدنا على القيام بأدق العمليات مثل جراحة القلب، جراحة المخ، وجراحة العمود الفقري. هذه الأجهزة متصلة بشاشات على مدار الغرفة تعطينا معلومات بشكل مباشر، تساعدنا في اتخاذ القرار الصحيح في الوقت الصحيح. واحدة من أكثر المرافق تميز في البرج الطبي الصيدلية المؤتمتة، ومن اسمها هنا عملية الحصول على الدواء أصبحت إلكترونية بالكامل دون أي تدخل بشري. الهدف من ذلك منع الأخطاء البشرية الوارد حدوثها وتسريع عملية حصول المريض على الدواء، وتقدم تجربة أفضل في إدارة المخزون حتى نتأكد من استدامة الأدوية، وتعطي فرصة أكبر في التواصل مع المرضى وتقديم الاستشارات لهم. يوفر البرج مرافق ترفيهية ورياضية تهتم بالموارد البشرية وتشغل تقنياته ومرافقه بأعلى كفاءة. البرج الشمالي يكمل رؤيتنا اللي تركز على الإنسان كونه هو تخصصنا. فعلا فخرنا اليوم بهذا المنجز ما ينوصف بالكلمات.
Good afternoon, ladies and gentlemen. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the first International Oncology Conference in Al-Ahsa. I am Abdurrahman Al-Suwailim, your host for today. First of all, I would like to greet Mr. Malik Al-Musa, CEO of Al-Musa Health Group, the oncology team at Al-Musa Hospital, our distinguished speakers from all over the world, and our honorable attendees. Before we start, let me brief you about Al-Musa Health Group. Investing in the healthcare sector as one of the vital sectors to society was driven by their long-drawn vision to focus on value-added projects that will provide better medical services to Al-Ahsa community. Therefore, the group invested in many healthcare projects over the past years. The healthcare sector's flagship was the main hospital, established in 1996 as the first private hospital in Al-Ahsa region, followed by the South Tower and the grand expansion of the North Tower. Al-Musa Health Group consists of Al-Musa Specialist Hospital, Al-Musa for Rehabilitation and LTC, Al-Musa College of Health Sciences, Al-Musa Health Home Care, Al-Musa Specialist Hospital in Al-Khubar, and Al-Musa Pharmacies. Al-Musa Specialist Hospital is a world-class healthcare system that promotes wellness and wellness, founded in 1996 as the first private hospital in Al-Ahsa, offering high-quality integrated healthcare. The hospital, ranked among the best 10 hospitals in the GCC, provides the patients with the best care in the Kingdom and GCC with the qualified, competent caregivers using the latest technologies and evidence-based medicine. Al-Musa Specialist Hospital is also an academic teaching hospital accredited by the Saudi Commission for Health Specialties, with 11 residency programs and 2 fellowship programs. The hospital provides the best human-centered care in a capacity of 500 beds, with a diverse team of more than 3,000 caregivers working together to achieve one mission, which is to promote hope and well-being for our society. The hospital leading programs and centers of excellence include the region's most favored bone and joint center, the Comprehensive Cancer Center, a world-class neuroscience center with a stroke program, advanced heart center with all the latest cardiac modalities such as the hybrid operation room and the electrophysiology lab. Also the region's largest and most comprehensive maternity and children program. As you can see here, Al-Musa is also accredited by many prestigious national and international organizations. Now, let's talk about the Oncology Center. First of all, it is the first comprehensive center cancer in the region, diagnostic, therapeutic, and support services under one roof. Certified medical technologies and nursing staff for the treatment of adult and pediatric patients, and exclusive radiotherapy with the most advanced modalities. The latest diagnostic devices including PET-CT and SPECT scan. Easy access to services without having to wait long time for results, enabling a quicker decision making and more effective intervention. Excellent patient journey and enhanced healing environment. Exceptional results in patient satisfaction as reported by the Press Guinea organization. The treatment and diagnostic services include surgical oncology, chemotherapy, radiation, nuclear medicine, interventional radiology, hormonal therapy, biological therapy, immunotherapy, palliative care, and intraperitoneal chemotherapy. Now, let's enjoy watching this video that demonstrates the Oncology Center of Al-Musa Hospital.
أطباء من تخصصات مختلفة لعلاج أورام الكبار والأطفال، ممرضات معتمدات، أحدث الأجهزة الطبية.
The hybrid operation room and the electrophysiology lab.
7 غرف للعلاج وتكنولوجيا نقدر نقيسها بالأرقام، لكن اللي ما تقدر تقيسها الأرقام الرعاية اللي أنت دايم محورها. كم طبيب فتح لك باب الأمل، وكم 7 غرف للعلاج وتكنولوجيا نقدر نقيسها بالأرقام، لكن اللي ما تقدر تقيسها الأرقام الرعاية اللي أنت دايم محورها. كم طبيب
Ladies and gentlemen, we are. Without further ado, I would like to invite on the stage Sheikh Ahmed Abu Al-Ainain for Holy Quran recitation.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والضحى والليل إذا سجى ودعك ربك وما قلى ما ودعك ربك وما قلى وللآخرة خير لك من الأولى وللآخرة خير من الأولى ولسوف يعطيك ربك فترضى ألم يجدك يتيما فآوى ووجدك ضالا فهدى ووجدك عائلا فأغنى فأما اليتيم فلا تقهر وأما السائل فلا تنهر وأما بنعمة ربك فحدث صدق الله العظيم.
Thank you so much, Sheikh Ahmed. I would like now to call upon Mr. Malik Al-Musa, CEO of Al-Musa Group and the Chairman of Health Committee in Al-Ahsa Chamber of Commerce, Board Member of Al-Ahsa Governor Region, Board Member of the second cluster of the newly formed Riyadh cluster as part of the Ministry of Health Transformation Plan, Member Boards of Trustees, Al-Musa College for Health Sciences, Member in the International Plant Tree Designation Committee, and a member of the National Health Committee in Saudi Arabia, to give an opening speech on behalf of Al-Musa Group team.
Assalamu alaikum. Good morning all, and thank you for joining us on this beautiful day in Al-Hassa. This is a great conference, just kicking off our new journey in oncology services. As you know, Al-Musa was driven by a mission to bridge the gap in services in our region. We were the first hospital to open, as a private hospital to open back in 1996, where people was traveling outside of our city just for normal procedures, like normal deliveries, simple procedures. People were actually traveling outside of Al-Hassa to get treated in other regions. Now this is, our services is available, but we continue also to bridge the gap in services from many services that we provide. Neuroscience Center, we were the first actually to offer the region the most neuroscience center, and so many other services. Now, the oncology, as you know, not only Al-Hassa, but there is a lot of many regions in the kingdom and across the world. There is a lot of lack of service in this field. there is a lot of patients waiting for many months to get appointments in different regions. And as you know, the suffering of not only the patient but the whole family while they travel outside of their own city and wait there for a lot of months and weeks just to get the right treatment and to seek the better treatment and options. This is hopefully will be available within their city, so no more patients will be traveling outside of Al-Hassa to get a simple procedure like PET scan or a SPECT or even radiation therapy or advanced procedures or surgical procedures. This is a service that we will all really proud of, and we thank you all for joining us to enrich the discussion and to kick off the new era of Al Musa, which is offering the most comprehensive oncology services. So thank you all, and hope that you will enjoy the tour in the hospital and tour in Al-Hassa, and wish you all the best. Thank you.
Thank you, Mr. Malik, for your nice speech. I would like now to invite Dr. Ahmed Antar, the head of this conference, to introduce you to the conference projects and themes. Dr. Antar is hematology and medical oncology consultant and chief of oncology center at Al Musa Hospital. Welcome.
Assalamu alaikum. Good morning, everyone. On behalf of the organizing and scientific committees, I am delighted to welcome all of you, distinguished speakers, academics, healthcare professionals from the Kingdom of Saudi Arabia, from GCC countries, and from all over the world, gathered here in Al-Ahsa to participate in Al Musa first International Oncology Conference. This meeting is unique. Indeed, it's the first International Oncology Conference taking place in Al-Ahsa region. And this is a very, very special timing for us, since we are celebrating the opening of Al Musa Specialist Hospital Comprehensive Cancer Center. We started the medical oncology service in February 2015. And since then, many milestones in oncology patient care have been achieved, including the development of the pathology lab. We get the CAP and AABB accreditation, significant progress in the interventional radiology services, launching of the pediatric oncology service, and the surgical oncology with almost all subspecialties. And most recently, we turned off the circle of multidisciplinary team care by adding the radiation oncology and the nuclear medicine services, with state-of-the-art technology that covers all modalities in radiation oncology, in addition to diagnostic and therapeutic nuclear medicine machines operated by highly experienced physicians, nurses, technologists, and medical physicists. In the coming 3 days, we will have a rich program covering most frequent or most common adult cancer in Al-Ahsa or in Saudi Arabia, breast cancer, colorectal cancer, lymphoma, leukemia, and almost all pediatric cancers, leukemia, lymphoma, brain solid pediatric tumors. This program will feature some of the world-class, renowned international, regional, and national speakers whose scientific work had been well recognized. So, start by a breast cancer session focusing on the screening, newest pathological classification, and the management updates in early, locally advanced, and metastatic breast cancer, from surgical, oncoplastic, radiation oncology, and medical oncology perspectives. The second session for today will cover the latest data on the management of pediatric brain tumors, lymphomas, and other pediatric solid tumors. Tomorrow, we will have a full day covering hematologic oncology, with a morning session about pediatric leukemia lymphoma and afternoon session about adult leukemia lymphoma and myeloma. These two sessions will focus on the emerging therapeutical modalities in the management of blood cancers that includes new targeted therapy, gene therapy, bone marrow allogenic transplantation and bone marrow transplantation, and CAR T-cell therapy. Moreover, tomorrow we will end the second day by a special event, a roundtable cases discussion with Professor Mohammed Kharfan Dabaja, Chairman of Transplant and CAR T-cell Program in Mayo Clinic, USA. And in the last day, on Saturday, we will have one morning session covering colorectal cancer updates from screening, approach, endoscopic treatment of early stage disease to medical and surgical and radiation therapy for locally advanced and metastatic disease. Furthermore, we will have a parallel session running today in the other venue that will cover oncology topics related to nurses, pharmacists, and clinical dietitians. And there will be tomorrow 2 oncologic nurses workshop. Finally, I would like to thank Al Musa Specialist Hospital Administration, our CEO, Mr. Malik Al Musa, and Chief of Academic Affairs, Dr. Zainab Al Musa, for their invaluable and continuous support to make this gathering successful. And big thanks also to all organizers and scientific committee colleagues who worked hardly in the last 6 months to make this unprecedented event happen in Al Ahsa region. Again, I would like to welcome all of you and wish you an enjoyable and inspiring conference. And thank you. Just I would like to remind you that on the back of the badge you have a conference booklet. You can scan this barcode to access the conference agenda. And for the physician track, you have another barcode you can scan to ask a question directly to moderators. Also, I would like to remind you that there will be a parallel session in the other venue. So please, for nurses and pharmacists and clinical dietitians who would like to attend the other session, go to other venue. And now I would like to welcome, we'll start our first session, breast cancer session. I would like to welcome our moderators for the first session, Dr. Abdul Muttalib Dandan. He's a medical oncologist from King Fahd Hospital, Hufuf. Dr. Muhammad Al-Duhailib, breast surgeon from King Fahd Specialist Hospital, Dammam. And Dr. Ibrahim Al-Uthain, radiation oncology chairman in King Fahd Specialist Hospital, Dammam. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Dr. Antar, for the invitation and for the introduction. It's my pleasure to start this session with my co-chairs. The first session will be given by Dr. Noor Naimi, who's a senior consultant in medical. She is the director of medical imaging at King Fahd Specialist Hospital in Dammam. She's also director of Mayil Jabr Screening Center in Dammam. Dr. Noor will deliver to us a very interesting talk about medical imaging and breast cancer.
Thank you, Dr. Ibrahim. Yes. Assalamu alaikum jami'an. Thank you, everybody. Thank you for attending. Thank you, Al Musa group, the organizing committee, the scientific committee, for giving me the chance to see you, learning from you, and sharing with you some of the knowledge I claim I know. Shall I use the flicker? طيب شو أسوي؟ Okay. طيب. Since Dr. Ibrahim was not, voice was not loud enough, I will introduce. I'm just teasing you. I work as a breast and women imaging radiologist in King Fahd Special Hospital. نقطع؟ Okay. كذا كويس؟ يدخل فين؟ طيب, the objective of my presentation is to go through standards, guidelines, and assessment and early detection, evaluating the standards that we are using and assess our tool, and going through some of the new trends and their impact on our management. I'll just go through a quick statistic just to know how far we are in managing the breast cancer, and is there a problem, or it's just an outside? It's in the globe problem, it's a global problem, or it's just in the Western country and we are away from this problem. Now, if this is an international, worldwide female breast cancer prevalence, and it's related to age as well. As you can see, the breast is almost fourfold in comparison to the next incident in the colorectal cancer. If we zoom our statistics, comparing what's happening outside to the Saudi Arabia or to nationwide, the breast is still number one when it comes to the higher rank cancer. Recently released King Fahd Special report. Thank you, Dr. Daama. It was released yesterday. We can appreciate that 44% of the top cancer sites in the Eastern Province are coming from the breast. In female, and in comparison to the male cancer, only 17 are colorectal. Also, if we can see here that the ranking of the top 10, breasts account for 28%. Still far? طيب. This is showing the distribution of the referral cases stratified by referring site. You can see that Dammam is the highest. Hassa is not far from it. I believe that the rest, we have less number of referral or percentage of referral because they are served by different healthcare provider. If we compare as well the stage that we are receiving patients seeking healthcare service, most of them are ranging between localized disease and regional disease, and we are not far away from the global age distribution. It's still between 40 to 60 years old, with average of 46 years old. Now we know there is a problem. It's not only global, it's even in Saudi, and we have a higher percentage of referral, all related to the breast cancer. So what are the needs? There is basic needs. You need to detect the disease earlier stage by screening. You have to grant a fast access to the service. You have to treat them by standard of care, and above all, not to do any harm. Let's start by defining how early it is, why we call it screening. Screening, that means you are dealing with a targeted group with no symptoms. So you can detect the disease before the appearance of any symptoms. So they have a chance of less interventional treatment and percentage of cureness higher. Again, we don't do it randomly or according to our experience or the way we used to do it. No, we have references. These are the most common references or standards or guideline. Most of them are used in management and imaging. Ours, as a radiologist, the mostly adapted is the American College of Radiology. طيب. This is a kind of busy slide. Just think of it in zones. This is the pathway we adapted in Eastern Health Cluster at the first Eastern Health Cluster to create a journey of early detection, management, and fast access. The first zone is your catchment area. This is the target area. You invite people, you invite your target people, you detect their eligibility, you do the risk assessment, and stratify them. Our target in any screening system or program is the average risk, not the high risk, not the low risk. That's why we go through the stratification and risk assessment session for every targeted group. After we localize our target, we move them to the screening service. Screening service by mammogram. Any screening available center in the cluster are providing the service, whether it's a mobile unit, it's a center, or it's a hospital. Our concern is the outcome of the screening, which is the mammogram report. If it is between 4 and 5, then we should grant a fast access to a secondary healthcare provider to get the biopsy and get the result and send them to start their treatment. Remember, we said we should not do harm. If we are not ready to accommodate all the outcome from zone 1 and zone 2, then we should not establish, because zone 3 is the area where we are supposed to be ready to accommodate all the product of our screening. For example, if I screen 200,000 in 1 year, this is a success. If I have 8,000 suspicious cases, this is another success as early detection. If I'm not capable of accommodating them at the other end, then this is a failure. Right. This is just a quick, remember I said initially we have to define our target, and our target are ladies between 40 to 70 with no symptoms. There is another way of defining the target, which is doing the risk assessment. What is the risk of getting breast cancer in 5 years and lifetime risk? This is one of the model we are using, Gale or COSAC. It's just an online, you can access it, it's a calculator. You can access it, put some data related to the patient, demographic data, family history, and other requested data. Then you will get 2 reports. One indicating the 5 years risk chance of getting cancer, and one is lifetime risk. The one we concern about is the lifetime risk. This is the tool that segregates average risk and above average risk, and I will tell you why. Now, our target in any screening program is the average risk, the patient who have less than 15% of getting the cancer. The remaining will go through a specific pathway. They have their own pathway of screening. The easiest way is doing, or the standard, as I mentioned earlier, is to do the screening mammogram. Now, it's a very simple procedure. It should not take more than 15 minutes door to door. Will take for each breast. This is an example of negative mammogram. This is just to challenge you. I'll challenge the surgeon. Don't. This is a case that's seen maybe 1 month back in our screening center. And we found something we thought we detected at an early stage. Can anybody see, surgeon? Right or left? This is right, this is toward the nipple or toward the pectoralis muscle? Sorry? Toward the nipple? Toward the pectoralis, or toward the nipple? طيب بما أن there is two different answer, this is reassuring that you will not take my job, so you miss the findings. طيب now, which one? The one at the outer, or there is another one? Yeah, exactly. This is an early detection, okay? The outer one is typical intramammary lymph node. طيب, what to do? We are a rich country, what to do? Shall we go to PET, CT abdomen? Shall we go to the contrast, MRI, diagnostic ultrasound, because she does not prefer mammogram, she's not comfortable with? What to do? No, not ultrasound, it's the standard. Yeah, in radiology we call them appropriateness. You see how appropriate is the tool to do to utilize it. Appropriateness means that it is diagnostic and the amount of radiation are acceptable. As you can see, diagnostic mammogram, this is an ACR, American College of Radiology, an ACR showing high rating, it is more appropriate to use it with a reasonable amount of radiation at the end of the table. While if you check the MRI without contrast, it is not appropriate at all, it is not diagnostic, there is no value, although there is no radiation. So we go through the standards. It's the appropriateness. In our case, it is diagnostic mammogram. Remember, that was a screening mammogram. So we compress the lesion. Obviously, it's a genuine lesion, not a fibroglandular tissue. And then we confirm it, we localize it, we confirm it, it's a 6 millimeter. This is a successful story. Reality is not like this. طيب. It's difficult to read it from here, but an early detection program, the goal is mainly to diagnose the cases as a result of abnormality in mammogram. That means you should not investigate a case and put her under screening while she's coming with the history of pain, endurance, mass. This is the aim of early detection is to detect it in mammogram before the appearance of symptoms. One of the most important things that 15% of cancers are occult in mammogram, despite the fact that till now, since like almost 40 years, screening by mammogram is the gold standard in the practice, but yet there are challenges and mammogram is less sensitive in minority of the group. Let me elaborate a little bit about the diagnostic mammogram. Remember we said when it's screening, it's two views. When you exceed, then it is diagnostic. Diagnostic can be 2D, 3D, compression, magnification, and also can be utilized as a guiding tool in interventional procedure. I'll give some examples. For example, this kind of calcification, you cannot see it by ultrasound. Although in this mammogram, it shows me that it is multicentric disease. خلاص, this is. The other thing that can be seen higher there is partially visualized dense lymph node. This is raising suspicion of metastasis. We can see findings as 2D or 3D. I can appreciate more lesions in 3D, which is the tomo. The other way of doing diagnostic is compressing a lesion to delineate borders and to magnify it to see more of the feature of the lesion. Mammogram as well can be utilized to biopsy under stereotactic guidance lesions, like lesions that not seen by ultrasound or microcalcification mostly, or by using the guidance to insert wire for conservative surgery. Going back to the challenges with mammogram, although it's a very beneficial tool, is the density. The more dense breast, the composition D or type D breast, the more challenging, the more missing chance of missing lesions under this kind of dense breast. Remember the case I showed earlier? It was fatty breast. That's why it was catched, sort of. So what shall we do? Yes, the diagnostic ultrasound. It's a very, very useful tool if it is utilized within the right context. We can use it to assess the size. Usually it evaluate or underestimate the actual size in comparison to pathology. We can assess vascularity, which helps in defining or road mapping our access and interventional approach. It can definitely show us the multifocality, multicentricity of the disease. This is the best tool to assess axilla and presence of lymph node. And of course, it's the best for when it comes to biopsy, clip insertion, and wire localization. Remember this case? We said we have calcification. It is multicentric by calcification, but to us, with a background of extremely dense, most likely this is DCIS, if we miss the axillary finding. Now, on ultrasound, we saw an axillary tail lesion, additional 2 lesions at 5 o'clock, and we could characterize the feature of the axillary lymph node. In addition to the guidance of taking biopsy. By standard, not in our hospital only, we label the passes. So each pass has to be labeled as with number. Also, if conservative treatment was the plan, we can use ultrasound to guide us to insert the wire. As you can see, there is a lesion. The whitish thing or the echogenic thing is the clip marker that was inserted earlier, and the linear structure is the wire that was inserted. Right, let's go to MRI. MRI have been misused by us, not utilized properly because it is available and we don't follow the standards. Let's just stick to the standard, we'll be safe, at least in 80% of our cases. The main reason we are using MRI in diagnostic setting is to define the extension of the disease and exclude, which is part of it, chest wall invasion. Of course, there are other indications in breast, like screening for high risk, but within a diagnostic context, it is to assess the disease extension. This is an example, but we'll go through the main indications. It is the chest invasion, disease extension, excluding multifocality and the multicentricity. Sometimes it is bilaterality, axillary involvement, although ultrasound exceed in accuracy the MRI. And we can use it as guidance when lesions are seen only on MRI. This is an example of axillary single nodule with chest wall invasion. You can see as well tethering of the skin. The extension of the disease is both sides, toward the chest wall and toward the skin. This is a single nodule seen on mammogram and ultrasound, but on MRI, we can appreciate the highlighted ones are all, it's a multifocal disease by MRI, which is upgrading the stage as well. This is, unfortunately, this is unhappy story. Maybe Dr. Dheirib is aware about it. This is a young patient, 26 maybe, presented with mass. So she has whatever is white or high signal is the disease. So it's a multicentric disease. MRI showed the linear structure, which is a linear enhancement within the muscle. So there is chest wall invasion. Since she's young, it's expected to have a dense breast. Remember the composition D? It was extremely dense. Nothing was seen by mammogram, not even by ultrasound. She's unfortunate that she has a multifocal disease on the contralateral side, which was not seen by both ultrasound and mammogram. In those cases, we have to do MRI-guided biopsy, and this is one of the utilization of MRI. Yes, Katie? Sure. 2 minutes? الحين بدأ يحلو الكلام طب I'll go fast with the contrast. It's basically giving contrast and imaging the patient, starting with the area of concern. If she's having a disease on the left, we'll start imaging the left side when we start after the contrast by 2 minutes. I'll go through some cases very quickly. This is a known case of breast cancer, but the background is extremely dense. So we wanted to know if there is anything else hidden within the dense background. Yes, there are multiple nodules toward the nipple. So it's a multifocal disease. Right. This is another example. This is a known case of right breast cancer post-mastectomy, presented with a newly developed lesion or shadow or density. On the ground, it shows a feature suggestive of cyst, so it is benign. However, she's a high risk, and there is a dense background. You cannot risk it. On contrast, two lesions seen on the contralateral side, highly uptaking the contrast, highly suggestive of cancer. This is a known case of DCIS. It's a known case, but we still appreciate some of focal asymmetry, unexplained. On contrast study, it shows a high uptake. This is another focus of the disease and an invasive component. Again, the indication of contrast mammogram given or applied because we know this is a cancer, but the background is extremely dense. We don't know if there is anything hidden and not seen by ultrasound. It shows another focus of the disease higher up, so it's a multi-centric disease. I wanted to skip this, like in her nice case. This is a known case of cancer post-surgery. The radiobac line indicates line of surgery with newly developed density. It's a distortion as well. You can see that it is distorted, pulled, and relatively it is related to the scar line, but we are not sure. With contrast, there is nothing. So we are assured this is a fibrosis within a healing scar. This is recently seen. Maybe our team in KFSH are aware of this case. This is a case referred with a clip marker indicating that we have done the biopsy and clip it, so it's a cancer-proven case. On our institution, we imaged the lady. We suspected another nodule just higher to it. With ultrasound, we appreciate the nodule, we biopsy it, it is cancer. So she has two nodules detected by ultrasound and mammogram. Now, our concern is the contralateral side. We're not happy about this. The usual pattern, alignment of the parenchyma, is pruning toward the nipple, like the one you see in the below here. But what's happening there that they are pulled somewhere. The alignment is distorted. This is confirmed. This is the two lesions we are seeing, along with smaller pattern of enhancement. I'm not sure if this makes any sense to you, but I'll try to explain it further. You can see that there is uptake. The whitish spots are an uptake of contrast. This should not happen. It should appear like the one below. Confirmed on CC. It's unfortunate. By MRI, we confirmed that she has bilateral multicentric disease. Does it replace the MRI? It should not replace the MRI, but recently, because we cannot be guided by contrast to take biopsy. Yani we can see things by contrast, like there was no tool to guide us to take biopsy to confirm the presence of disease. Recently, we can. So it's a very promising tool. It's a fast access, cheaper, and you can access it for interventional procedure. I'm done. Let me just put some points very important that we should treat every patient individually. It's not one size can fit everybody. Our priority should be giving the care as per standard. We do have a lot of tools, like in the idea and the smartness is not to use all the tools. I should not bring my patient to do for them PET because I have PET. This is not the way we should manage. And each patient, each individual should have an individual approach. I'll just conclude. I cannot read من الجنب. Breast cancer is not preventable disease, but controllable if detected at an early stage. The guidelines criteria address the image workup of women with different stage of breast cancer specifically, regarding which image test should be done to rule out unexpected metastatic disease. Individual case-specific approach need to be considered as a management strategy. precise disease extension, which is the main reason we are doing the imaging, is an initial or essential step in the management. The more you see, the more you can manage. Thank you.
Thank you, Dr. Noor, for this elegant and informative presentation. So our next speaker is Dr. Hamid Al-Jawad, consultant pathology and director of the Academic Specialist Hospital. Dr. Hamid will present an update of HER2 testing in 2022.
Yes. Good morning. Thank you for inviting me here to talk today about HER2. We need the slides. About interpreting HER2 in breast cancer in this year, 2022. During this talk, in less than 20 minutes, I will discuss the changes that happened to the significance of HER2 since it was discovered, and then I will discuss quickly how the labs can assess HER2, mostly in immunohistochemistry because that's what I do, and then we will see how the labs can produce consistent, reliable results, and finally I will discuss the latest guidelines that were published by the American Society of Clinical Oncologists and College of American Pathologists in scoring and reporting HER2. Sure. And I can't see, so that I have to move. In the 17th century, a French philosopher said, doctors put drugs of which they know nothing into bodies of which they know less for diseases of which they know nothing about. Today, this definitely has changed toward precision medicine, and targeted therapy is the future mega trends. Herceptin, a HER2 targeted therapy, was first approved for treating HER2 positive breast cancer in 1998, and since then data accumulated showing that HER2 negative breast cancer can show low level of protein expression, and newer therapies arrived and tried in clinical trials, showing that some patients may improve with newer therapies. In August of this year, okay. Sure. عشان تكون الأمور واضحة. Okay, testing. Are we okay now? Okay. Okay, thank you for the help, and we apologize for this technical issue. I will continue. On August of this year, a newer target therapy was approved by USA FDA, and this is the first targeted therapy for HER2-low breast cancer for metastatic and unresectable breast cancer. In the next few slides, I will discuss what is the meaning of HER2 positive and what is the meaning of HER2-low breast cancer. HER2 is a gene located in chromosome 17. It encodes for a protein which is present in the cell membrane of epithelium. The normal epithelium expresses extremely low levels of protein, and when HER2 gene is amplified, HER2 expression will be overexpressed in the cell membranes. HER2 positivity is correlated with aggressive breast cancer type. When, if not treated by HER2 targeted therapy, it will have poor outcome. For therapeutic purposes, primary breast cancer is classified into based on hormone receptor status and HER2 status into HER2 positive disease, which is happening in 15% of breast cancer. The remaining breast cancers are HER2 negative, sorry, HER2 positive. In the lab, we have two gold standard methods to detect HER2 result. The immunohistochemistry and in situ hybridization. In immunohistochemistry, it is applied on formalin fixed paraffin embedded tissue. It utilizes antibodies that will target overexpressed protein receptor for HER2 in the cell membrane. It takes about 2 hours to complete this procedure and about 1 day to report. In situ hybridization also can be applied on formalin fixed paraffin embedded tissue. It utilizes DNA probes to identify HER2 genes in the cell nucleus to identify gene amplification. And it takes about 8 hours for this procedure to complete and about 2 days to report. The guidelines for HER2 testing have been continuously evolving to meet the changing clinical needs. HER2 testing was first approved in 2000 for immunohistochemistry and in situ hybridization, and since then many changes happened in 2007, 2013, and finally in 2018. The changes are mainly to address concerns regarding the definition of positive and negative disease and to address false positive and false negative results, and finally in 2018 provided recommendations HER2 test if the result was negative in core biopsy. The guidelines historically and until now focused on separating HER2 positive from HER2 negative breast cancer. Now in this graph, which is the latest guidelines approved by the American Society of Clinical Oncologists and College of American Pathologists, it is immunohistochemistry and in situ hybridization procedures to determine the level of HER2 protein overexpression and gene amplification respectively. For immunohistochemistry, score 0 and 1 plus, this means negative HER2 result. Immunohistochemistry score 2 plus means equivocal result, which would require a reflex in situ hybridization test to give us a negative or positive result, and sometimes it can also give an equivocal result. Finally, score 3 plus by immunohistochemistry means positive HER2, and it will be eligible for the usual HER2 targeted therapy, Herceptin. Now, what the pathologists see under the microscope for each score is defined by this criteria. For immunohistochemistry score 0, it is either flat negative, no staining, or very rare, barely perceptible, incomplete membrane staining in less than 10% of the tumor cells. For immunohistochemistry score 1 plus, there is faint, barely perceptible, incomplete membrane staining in more than 10% of the invasive cancer cells. Score 0 and 1 plus are negative by this criteria, which is the latest. Immunohistochemistry score 2 plus, which would show weak to moderate membrane staining in more than 10% of cancer cells, or strong complete membrane staining in less than 10% of the invasive cancer cells, and it means equivocal result. Immunohistochemistry score 3 is the only score that would go for treatment by HER2 targeted therapy, which shows straightforward, strong, intense, complete membrane staining in more than 10% of the tumor cells. But now this is changing because we know there is a spectrum of HER2 expression which is beyond positive and negative. Although 85% of HER2 breast cancers are identified as negative, we know that 50% of breast cancer, the metastatic breast cancer and recurrent and unresectable breast cancer, they show variable level of HER2 protein expression in the cell membranes. And because we know that there is a new treatment that came in August of this year, which is approved for these cases, we need a clear guidelines that will tell us how to identify HER2 low breast cancer cases to be eligible for this new treatment. On the left side here, we have proposals from the published data. Those cases with immunohistochemistry of score 1 plus without need for in situ hybridization, and those with immunohistochemistry of 2 plus are most likely going to be considered HER2 low breast cancer in the next guidelines. Few data also suggest that even those with immunohistochemistry score 0 that show minimal staining, they may also be eligible for this treatment, but this is not sure for now, and they would like to call these as ultra-low HER2 expression. Now, how can we in the lab can give you consistent and reliable immunohistochemistry results for HER2? First, before offering this test for clinical service, we must validate this test. Validation means you need a number of cases that you run in your lab showing or should match the results that were done in another lab. The other lab should be previously validated for this test. For now, the CAP guidelines require 80 cases to go through this procedure. Half of them should be HER2 negative and the other half should be positive. You should use FDA approved kit with known sensitivity and specificity, and those cases that you run for this validation should conform with all the guidelines that we'll discuss in the next few steps. After having a validated test, there are a number of variables standardized to have improved results. In the pre-analytical phase, the focus is toward having optimal tissue requirements, meaning First, you should use only 10% buffered formalin because it is the only fixative that is approved for clinical HER2 testing. Second, you should have ischemia time of less than 1 hour. Ischemia time is the time that is between acquisition of the tissue by the surgeon until the time it is placed totally and submerged in formalin. This time very likely to be very short, 1 minute or less if this is a core biopsy, but if this is an excision or mastectomy, the time will include transportation from the OR to the lab, grossing, sectioning, and having 5 millimeter thickness tissue. And finally, the fixation time. Fixation time is the time for the tissue that remained in the formalin, and it should be between 6 and 72 hours. Over fixation or under fixation will result in a number of false positive and false negative results. Now, in the analytic phase, you again should use an approved kit with known sensitivity and specificity. And for each run you run for the cases of your patients, you should have working positive and negative controls. The post-analytic phase is the time where the slide reaches the pathologist for interpretation. The pathologist should be trained how to score and recognize artifacts, and they should undergo quality assurance with ongoing competency assessment with proficiency testing material from outside your hospital. And for best practice, a second pathologist should read for borderline and challenging cases, meaning immunohistochemistry score 1 and immunohistochemistry score 2 results. The lab should conduct trend analysis for their results annually to see if they are belonging to the international benchmark. The report must include distinct immunohistochemistry score and should report the intensity and the kit and primary antibody clone number used. And the report should also include the pre-analytic variables that are the ischemia time, fixation time, and type of fixative used. Now, you should repeat HER2 in the core biopsy in the following condition. If the tumor in the core biopsy was grade 3 and it is negative, you should repeat the test in the excision. If you have a small tumor volume in the core biopsy, repeat it in the excision. If the resection shows high-grade carcinoma that looks completely different from that high-grade carcinoma in the biopsy, repeat the test. If the core biopsy shows HER2 result negative, both in situ and immunohistochemistry, repeat it in the excision. And finally, if you suspect that there is a problem because the tissue came from outside hospital and you don't know anything about the fixation time, ischemia time, and type of fixative, repeat it for the benefit of the patient and according to the guidelines. Now, in conclusion, HER2 is a prognostic and predictive biomarker for treating breast cancer. HER2 is primarily evaluated to determine eligibility for treatment. And the current guidelines interpret HER2 as positive and negative, but we know now that there is protein overexpression that would benefit from newer therapy, and we are awaiting for newer guidelines that will tell us how to define and identify protein overexpression. And finally, those with immunohistochemistry score 0 are unlikely to be treated with the newer therapies. Thank you.
Our next speaker. So now we move to our next speaker, Dr. Abdulatif Al-Sharif. Dr. Abdulatif is a consultant in nuclear medicine at Al Musa Specialist Hospital, and he will present molecular imaging of breast cancer. So please, Dr. Sharif.
For this nice presentation. Thank you, everybody. I hope you hear my voice. So can we start? Do you have my slides, please? Okay. So my talk today will be about molecular imaging of breast cancer, the current status and the future perspectives. Currently, we have, as most of you know, we have two radiopharmaceuticals that are widely accepted by most clinical guidelines in the management of cancer. These are fluorodeoxyglucose, better known as FDG PET, and sodium fluoride PET, better also known as NAF PET. Okay, now, more recently, another radiopharmaceutical has been approved by the FDA, which is known as fluoroestradiol, FES-PET, and this is gaining momentum now in nuclear medicine. Other radiopharmaceuticals do exist in the clinic, in research laboratories, namely fibroblast activation protein, very soon in the clinical practice, epidermal growth factor imaging agent, which is known as trastuzumab, labeled by zirconium, and programmed death ligand, also, which is known as atezolizumab, PD-L1 agent, is also in the cockpit of nuclear medicine. I will not be discussing everything. I will be focusing on FDG, NAF, FES, and FAPI. Now, all of us know FDG, but a reminder for those who are not, who do not know what is FDG. FDG is an analog of glucose. Most cancer cells consume glucose and consume it a lot. Why? Because a normal cell uses one molecule of glucose to produce 38 energy molecules, 38 ATPs. A cancer cell does not do that. A cancer cell uses one molecule of glucose to produce only 4 ATPs. And this means that it needs lots of glucose to build itself and to generate more energy. What is FDG? FDG, it is an analog to glucose. It's taken by the glucose cell, by the cancer cell, and accumulates because the cancer cell is not able to degrade it furthermore. So that's why a cancer cell accumulates FDG, and that's what we use in nuclear medicine to image our patients. So our first lecturer told us about appropriate use criteria. In order to get a useful information from a PET scan, you need to know when to ask for a PET scan. Do we use PET scan for invasive, for diagnosis of cancer? We don't use it. Of breast cancer, we don't use it. Do we use it for non-invasive DCIS or LCIS? No, it's not indicated. We use it in some cases of invasive breast cancer. According to the NCCN guidelines, we use it in staging, stage 1, 2, 3, and 4 breast cancers, only to solve problems, only when we face equivocal cases. A lung nodule that we are not confident, is it metastatic or not, so we ask for a PET scan. A bone lesion that's sclerotic, probably metastatic, we ask for a PET scan. This is the NCCN guidelines. Now, patients with inflammatory breast cancer have very avid FDG uptake, and these cases must do a PET scan, and the PET scan in this case can replace a CT with contrast and can replace bone scan. So if you do PET scan for these cases, no need for bone scan or no need for CT scan. On the other hand, lobular cancers, as you might see there, is characterized by low FDG uptake. And low FDG uptake means that the sensitivity of the PET scan is limited. So you don't do PET scan for these cases. More recently, the Royal College of Physicians and the Royal College of Radiologists from the UK published this paper. It's evidence-based indications for the use of PET-CT in the United Kingdom 2022, published just a few months ago. And they're telling us that FDG PET, again, is performed only in equivocal cases, particularly before therapy, and in staging patients with inflammatory breast cancer before surgery. But they go one step further, and they're telling us
PET-CT is suggested in patients with T1 breast cancer, because T1N1 or T2N0 breast cancer, and is strongly recommended. Now, this is novelty. This is strongly recommended in patients with stage 2B or more breast cancer. It is suggested in patients with aggressive tumor pathology, such as triple-negative cancer, and it can replace other imaging modalities when we can't perform them for other reasons. For example, allergy to contrast or renal impairment. The French and the Italian societies of nuclear medicine published before the British, the same recommendations. They are telling us that PET scan is optional in stage 2A breast cancer, and it is highly recommended in patients stage 2 or B breast cancer. We are not using it. We are using it in staging. Why is that? Because approximately 30% of stages 2B cancers are upstaged if you use PET scan. And this will definitely change the management of our patients. Now, we did the PET scan. Can we get more information from this PET scan? Of course. Dr. David Grohu, since the early 2010s, tried to drag our attention to the prognostic value of PET in breast cancer. It has been consistently reported that ER-negative cancers have higher FDG uptake, higher SUVs. PR-negative cancers have higher FDG uptake. HER2 does not affect FDG avidity, and this has been also consistent in the literature. The most consistent thing to know in the literature is that triple-negative cancers have higher uptake than non-triple-negative cancers. Histological grade 3 cancers have higher SUV values. P53 mutated cancers have higher SUV values. This actually ends up in a summary that has been consistently reported in the literature and summarized in this meta-analysis over 3,500 patients. And in this meta-analysis, they have two important conclusions. High SUV is related to higher risk of progression, and low SUV is related to better survival outcomes. So the SUV value itself has a prognostic power. This has been demonstrated very nicely in this paper, published recently. And in this paper, they took 125 female patients. They used the SUV. They tried to find a threshold where we can identify which patient can perform better than the other. And look at the curve here. An SUV, that the line in green, is an SUV of 8.6. And these patients are doing much better than patients who have higher SUV values above 8.6. So SUV of 8.6, which most of the time correlates to a grade 3 cancer, a triple-negative cancer, to start with, when you do it at diagnosis, you can predict that this patient is not going to perform very well. Other indications for FDG PET cancer is evaluation of neoadjuvant therapy response, chemotherapy response, particularly again for triple-negative cancer and HER2 cancers. It is very useful in assessment of treatment response to systemic therapy, particularly for those patients who have diseases that are not easily detected by other cancers, such as bone metastasis. A bone metastasis is not easily detected on CT or on bone scintigraphy even. So use PET scan not only to assess the presence of disease, but to demonstrate the response to chemotherapy. And in treatment of patients with complex metastasis, multisystemic metastasis, where sometimes some metastases respond better than other metastases, so you need a PET scan to identify how tumor in different sites is responding to this kind of treatment you are delivering to these patients. Now, the prognostic value of FDG PET also has been studied in several papers. This is a paper that was done on over 1,630 patients. It's a meta-analysis. And again, we have two important conclusions in this study. It's interim and end of treatment PET is significantly associated with pathological response, and metabolic response to neoadjuvant therapy is a significant prognostic factor in terms of disease-free survival and overall survival. This is true for interim and for end of treatment PET. Yet, I need to draw your attention for one thing. When you as a clinician try to assess the response of the tumor in the breast itself, the breast lesion itself, We can use PET for interim evaluation. It performs, this dark line performs much better than MRI in the interim situations. But at the end of treatment, we still recommend MRI to assess the response to chemotherapy. So at the end of treatment, MRI actually outperforms PET when we are talking about the breast lesion itself. Assessment of recurrence. Can we use PET to assess recurrence? Of course. Conventionally, we use CT scans and bone scans, but yet we can use PET scan to solve problems. That is, again, a lymph node that's suspicious, and PET then will solve the problem. A patient with a negative conventional imaging and elevated markers, what better than PET that you have that can solve this problem? Differentiation of treatment-induced brachial plexus plexopathy. It can be a tumor infiltrating, or it can be neoplastic. Again, this is a role of MRI, but nuclear medicine can play the role to solve the equivocal cases. This is an example. A patient with plexopathy with the hotspot determining confirming malignant infiltration. In the absence of FDG activity in the brachial plexus, we can actually confirm that this patient does not have neoplastic infiltration of the brachial plexus. So I need to cut it short for the FDG because I think most of the clinicians know a lot about FDG, and I'm proceeding to other tracers. NAF PET scan for bone. It's a scan for bone. It's a bone PET scan. It has the same principles, the same pathophysiology of bone scan that we already know, but it has higher contrast, low background. So NAF has been available since the 1972s, before the advent of PET-CT. You know that the PET machine existed in the early 1960s, but it was fused with the CT in the year 2000. So we have FDA approval of NAF for detection of bone metastasis since 1972. And it is included in most clinical guidelines as an alternative to stage bone metastasis, particularly when we have crisis of technetium shortage, as the one we are having now. NAF bone scan actually is the most sensitive technique. Its sensitivity approximates 100% to detect bone metastasis. It's more sensitive than the conventional bone scintigraphy. It is more sensitive than FDG PET, but it is with this increasing sensitivity, we are sacrificing to a bit some specificity. So it is sensitive because it can detect most osteoblastic lesions, and it can detect them quite well. But it has a limitation. This limitation is known as the flare phenomenon. I'm sorry you can't see that. Now, the flare phenomenon is increased activity of the lesion on the scan because of bone repair due to the osteoblastic activity. This is a limitation of FDG, of NAF PET, that is not there for the FDG PET. One important thing that I need to remind you about is that FDG actually performs very well in detecting bone metastasis in breast cancer. It can replace bone scintigraphy and NAF PET scan if it can detect metastasis on both the PET component and the CT component of the study. So my question, it is very sensitive. You're telling me it's very sensitive. It's not as specific, and it suffers from the flare phenomenon. And I have a bone scan, and technically it's conveying the same information. When should I do PET? And this is a very fair question by the clinician. This study aimed to answer this question, and they are giving us two suggestions. You do PET when you have sclerotic lesions in a bone scan that are not avid, they are not hot on a bone scan. You see them also in an FDG PET scan. You're still suspicious, and they are not avid on FDG either, and you're still suspecting this could be metastasis. So you do an AF bone PET. Another scenario is that you have a patient with breast cancer with a single oligometastatic bone lesion. You want to treat that radically. So what would you do? you need, before going through radical treatment, you just need to confirm by the most sensitive technique that you have that this is actually an oligometastatic lesion. Okay, enough for bone scan and bone PET. Let's go for the more recent tracer, which is known as Cerianna. Cerianna is a fluoroestradiol agent. It is a PET agent that images estrogen receptors. Now, Cerianna has been available in nuclear medicine laboratories for more than 30 years by now. But a company from France known as Anexa has produced a stable molecule, and it got the FDA approval in the 2020, few months ago actually. And the approval is like this. Please read with me the approval. Approved for the detection of estrogen-positive lesion as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. So this is what Cerianna has been approved for. And this comes with a limitation. The limitation is that tissue biopsy should confirm recurrence, and the estrogen receptor status should still be confirmed by pathology. So we are not yet replacing pathology. Why do we need to image estrogen receptors in a patient with breast cancer? Clinicians know, because there is heterogeneity in estrogen receptor expression within the tumor itself, between different foci of tumor, between the primary and the metastasis, and even a lesion itself, with progression of treatment, with medications, can it change its estrogen receptor status. And this can be up to 40% of cases in heavily treated patients. Now, this is an important paper and one of the papers that led to the approval of Cerianna, of FES PET. It was published in Lancet Oncology 2019, and it proved the safety of FES PET, but it had a very interesting feature finding. Over 85 patients with breast cancer, they analyzed PET, FES PET, with estrogen receptor status. And the negative correlation was 100%. So if FES PET tells us there is no estrogen receptor, then there is no estrogen receptor. Unfortunately, positive correlation was only 76%. And that's why the condition, that's why the limitation. You need still to confirm the presence of estrogen receptors by histopathology, even if you do Cerianna PET. Okay, when do we use FES PET? This paper, published in Journal of Nuclear Medicine, tries to answer this question. They tell us you do FES PET to solve problems. What kind of problems? Inability to identify the extent of metastatic disease, unclear estrogen receptor status of the tumor, or inability to determine which primary tumor caused metastasis in patients who have more than one tumor. The paper demonstrated that FES PET actually can solve most of the problems. That this blue line means the problem solved. So most problems were actually solved by FES PET. And this is really fascinating. We have now a tool that can guide us through the management of patients. This is an example. This is a patient with bone scan and ankylosing spondylitis and breast cancer. You see the hot spots there in the spine. I'm, as a nuclear medicine physician, and I consider myself as an expert, I would have passed that as degenerative changes easily in a patient with ankylosing spondylitis. The clinician in this case has the power to add FES PET to his exam, to his patient, and he sees all these hot spots in this patient. So this is a patient who has breast cancer metastasis, and FES PET could solve the problem. So nothing comes without drawbacks. This is an FES PET, again, imaged as you can see. See the liver, how hot the liver is? You can't see a lesion in the liver with this hot liver. So FES PET scan still cannot identify liver metastasis. We need another tool. Another important question in breast cancer is, can FES solve the problem of limitations of limited FDG sensitivity in lobular breast cancer? The answer to this question is really difficult. We still don't have enough literature to answer this question. But this is a very important paper that tried to answer this question, published just a few months ago, or 1 year ago. Now, it is a head-to-head evaluation between FES PET and FDG PET. It is a retrospective study, but its data came from 6 prospective papers. They identified 92 patients of breast cancer who had FES PET and FDG PET. Of these 92 patients, only 7 cases had lobular cancer, and only 7 cases had both scans without intervening treatment. These are the images of these 7 patients. I brought you all the images. The upper row is for FES PET, the lower row is for FDG PET. As you can see from our first 5 cases, the FES PET identifies more disease. All these hot spots on the PET means disease. It's much better and much superior and much more specific even than FDG PET. The last 2 cases, it's the other way around. Let's look at the last case. The last case, the patient has liver metastasis that was not detected by FDG PET. Of course, I told you why. Liver background really is a problem in FES PET. On the other hand, the 6th patient had bone metastasis that was detected by FDG PET and not on FES PET. This means that the patient's metastasis actually, this is good also piece of information. The clinician will take advantage of this piece of information. Metastasis here will not respond to anti-estrogen treatment. And this patient is losing the estrogen expression of the metastasis. So although the scan is negative, still we have clinically useful information from this scan. The conclusion of this paper was FES PET compared favorably with FDG PET in patients with cancer. It's a powerful tool that we have. I hope we can add it soon to our clinical armamentarium here in Saudi Arabia and in our region to help in the management of breast cancer. Now, another important useful value for FES PET would be assessment of the estrogen receptor.
Dr. Abdulatif, you have 2 minutes.
Okay. Now, is the assessment of estrogen receptor availability after treatment and prognosis. This is a patient who has this is before treatment and after treatment. Most of the lesions have disappeared, other lesions did not. It means that the clinician has 2 alternatives. Either change it, escalate the treatment, change it, or go towards radiation therapy. Now, the last important tracer that I will take about is FAPI. FAPI, it images fibroblast activation proteins on tumor cells. And FAPI is expressed on CAF, which are cancer-associated fibroblasts, and these represent 90% of the tumor mass in most case scenarios. And it is characterized by rapid clearance from the background. This is a FAPI image. This is an FDG image, and this is a FAPI image. So you can see the breast lesion, how it is very well expressed on a FAPI. FAPI actually has proven superiority in detection of breast cancer and in detection of brain metastasis because there is no activity in the brain. In detection of bone metastasis, hepatic metastasis, and lymph node metastasis in patients with breast cancer. This is an FDG PET, and that one is a FAPI PET. Look how nice the FAPI PET images look. So this is going to add to our clinical armamentarium. Some clinicians now are trying to label fatty with molecules that can burn the tumor from the inside in the field that we're now calling as theranostics. So this is an added value for our PET scan. Does FAPI solve the problem of lobular breast cancer? This is the only paper that I could find in the literature that targets FAPI and intraductal carcinomas. And as you can see there from the last 2 boxes, that there is no difference in the uptake of SUV between lobular and ductal cancer. So this means that FAPI can solve to us the problem of lobular breast cancers. Again, we are now having some clinical studies. This is one of the most important studies known as the Impact MBC study that's trying to evaluate that each patient with breast cancer should have FDG PET, HER2 PET, and estrogen receptor PET in order to enable the clinician to target each lesion specifically. We are all curious and waiting for the results of this study. our society, the Society of Nuclear Medicine, is encouraging clinicians to investigate more on lobular cancer. I advise you all to start investigating FAPI and induce FAPI to our clinical practice soon in Saudi Arabia. And even people like Bill Gates are opening their eyes towards nuclear medicine and new radiopharmaceuticals in nuclear medicine. He has just established a company to produce radiopharmaceuticals. And let's read together the motto of the company: supporting the transformation of the fight against cancer by advancing the next generation of isotopes. So this is the motto of his company, TerraPower. And this is where medicine is going, towards molecular imaging, towards personalized treatment of cancer. Thank you. Thank you all.
Thank you very much, Dr. Abdul Latif, for the nice presentation and thorough presentation. So it gives me a great pleasure inviting the next speaker with no further delay, Dr. Yazan Masanat. Dr. Yazan is a consultant oncoplastic breast surgeon at Aberdeen Royal Infirmary Hospital, and he's also one of the associate postgraduate deans at NHS Education for Scotland. He is an honorary senior clinical lecturer at the University of Aberdeen, and he is an tutor with the University of East Anglia, if I'm correctly pronouncing it. He is one of the board trustees of the Association of Breast Surgery, as well as a member of their education and training committees. He is the communications lead at the iBreastNet, which is, I have the pleasure to be part of it also. And he is being an examiner at the European Board of Surgical Oncology and European Board of Breast Surgery exams also. There are a lot of things to mention about Dr. Yazan, but I have limited time. Dr. Yazan, we have 20 minutes presenting the oncoplastic surgery, pushing the limits of breast surgery. I wish this is an enjoyable time. The floor is yours, Dr. Yazan.
Thank you for the presentation, and thank you for inviting me, both of you, Dr. Muhammad and Dr. Hanan, to be part of this conference. We'll wait for a couple of minutes because there was issues with my talk. It works on two computers, but I hope it will work on the main computer. The talk, I've tailored a 45-minute talk down to 25 minutes. So you tell me when to stop. I was told that the first talk will be mainly entertaining more type of talk with lots of videos. So there will be lots of videos towards the end of the talk, and we can cut some of those videos. So as mentioned, I'm one of the surgeons in Aberdeen, and I do also have some other roles in the UK and in Europe. And I run the iBreast Book webinars. Those are free educational webinars for anybody that wants to do breast surgery. The only reason to mention them is that some of those are sponsored by the companies, and there's no conflict of interest, and there's nothing to declare. The sponsorship has no relation to this talk. So when we talk about oncoplastic breast surgery, we need to start from the beginning. And breast surgery before oncoplastics was mainly mastectomy and breast conserving surgery, 2 operations. And then oncoplastics came, which is the new kid on the block. It came in the 1990s, and the first description of that was by Aldrich. But things have developed big time in the past 15, 20 years, and what we do now is completely different what was done 20 years ago. So where do we start? When you start any story, you need to start in the beginning. And of oncoplastics is to do a good mastectomy. Mastectomies nowadays are different. You should aim for a neat scar, you should aim for a low scar, and you should aim for a flat chest. And if you cannot do a good mastectomy, you should not be doing any breast surgery, because this is better for the prosthesis for the patient. This is better for the patient because you cannot see the scar when they wear a low top. And when you do your future reconstruction, it's better to have a low scar. So something along those lines. But mastectomies are better now. We can do a good reconstruction, but nothing will replace the breast. So for example, I'll give you just some few examples. This is a lady with a Paget's disease, had a subpectoral implant. good symmetry in her when she wears her top. Another lady on the days that I used to do subpectoral with keeping the nipple, the right side, I had to remove the nipple on table because frozen section was positive. And this is a lady with bilateral augmentation that I've done a prepectoral mastectomy on the left side and put an implant. With the free flaps, you also can get some good results, which is this is a Dieppe flap. This is another Dieppe flap on the left side with tattooing, and this is a Dieppe flap. When you push the limits with the plastics, you still can keep the nipples with the Dieppe flaps. And when we plan the mastectomies, you need to think about the mastectomy and the type of the patient, the type of mastectomy that will be doing, the patient and the cancer treatments, and trying to avoid this. We all have complications. If you haven't seen complications, then you haven't operated. This is a dead flap, and this is a nipple. This is an implant that has extruded. So I'm going to mention a couple of things on top of the mastectomy, mainly about skin nipple sparing. In the past, people were dubious about doing any reconstructions, immediate reconstruction, but the data suggests that immediate reconstruction people do as well. The chance of overall survival and recurrence is the same. And if you keep the skin, that does not affect the local recurrence or overall survival. So in certain cases, you can keep the skin. You need to be very careful with extensive DCIS and tumors that are close to the skin. But in general, it'll give the patients far more superior result if you keep the skin. And there is lots of papers. This is one from Carlton about 10 years ago. They summarized the data of local recurrence in skin and non-skin mastectomies. And you can see there is some, the local recurrence rate is quite low, but there's lots of caveats and bias. We're not going to go through that. A couple of examples how you do your mastectomy. So you can do it with a circumareolar ellipse, and you can get this result which you've seen before, or when you put an implant, you get something along those lines. Or you can do a Weiss pattern. It's a bit more tricky and more challenging to do a Weiss pattern mastectomy, but usually it works well. And always try to keep the nipple. If you can keep the nipple, it's gaining popularity. It does, when you do it for a BRCA positive patient, it does lower the risk reduction from 95% to 90%, but they give them far more superior aesthetic outcome, and there is no data to suggest that it is not safe. In fact, all the data suggests that it is at least equivalent. It's not always suitable for all. For example, we go back to this lady of done bilateral mastectomies. Unfortunately, the frozen section on the right side was positive. I had to remove the nipple, but remember, not everybody will agree with this. The nipple is not the areola. So some people remove the whole areola, but you really don't need to remove the areola. Some ladies have a 5 and 6 centimeter areolas. If you remove that, there's not much skin left on the breast. And some ladies, you can give them better aesthetic outcome when you do the mastectomy. Now, the type of reconstruction, we're not going to go through that because there's lots of things to talk about the type of reconstruction. We'll concentrate a bit more about breast conservation because this is where we can push the boundaries to try to keep breasts. And we know all the data from years ago from the Milan trial and from the trial by Fisher and SAB B06. And we know that the 20-year follow-up data on breast conservation versus mastectomy is equivalent. So we don't need to argue that breast conservation is safe. In fact, the new study by the Swedish cohort showed that some ladies with breast conservation might do even better than mastectomy patients. But in the past, all the RCTs have excluded large tumors. So if the Milan study was only up to 3 centimeters tumors, some of the studies went up to 4 centimeter tumors. So not all T2 tumors were included. They excluded, of course, locally advanced tumors, inflammatory cancers, multifocal, multicentric breast cancer, and central tumors. And you'll start questioning why. So it's mainly because years ago, it was quite new to them. They did not know as much about oncology, and they felt it's not safe to operate on those patients. And also because of cosmesis, you'll get those results sometimes when you do bigger excisions. So that's why people were shying away from conserving those breasts. But that's where we start pushing the limits. Things have moved on from the 80s and the 90s, and things are much better nowadays. Your technology is far superior Radiology is better, and we had lovely talks about radiology before. Pathology is better, and we had lovely talks about pathology also before. And oncology is better. We have much more targeted treatments. So let's look at all those exclusions one by one. Large tumors. Many papers have boasted about excising large tumors. There is no RCTs. We will never have RCTs about large tumors. But this is the paper from Chris Shrakloff. And you can see up to 16 centimeter tumors were excised. Also, the term extreme oncoplastic surgery has been started by Melvin Silverstein, which is mainly excising anything more than 5 centimeters, T3 tumors. And there is, if you look at the local recurrence rate in that cohort, comparing the extreme and the standard breast conservation, it's very similar. And we all have those patients. This is a lady with an 8 centimeter phylloides tumor that was offered a mastectomy, but you can easily do a small vertical scar, remove the 8 centimeter, reshape the breast, and still keep her breast. And I always put this case because this is the first case when I started as a consultant, wanted to conserve an 8 centimeter area of DCIS in a hospital that used to do mastectomies for all those patients. And you just need a radiologist to be able to put the wires for you, bracket everything, you know that your excision is fine, and you get a reasonable aesthetic outcome. Now, locally advanced cancers, there's many that are not operable, so don't venture into operating. Some are operable. This is a malignant phylloides, was growing by the day, and this is also a metaplastic carcinoma, but you need to choose your battles. You need to choose who you can operate on, who you cannot operate on. And some locally advanced cancers, by definition, they can be just going through the skin, but they're still conservable. So not all locally advanced cancers are locally advanced cancers by the definition that we think of. Central tumors, also they excluded central tumors because of aesthetics, but there's lots of techniques. You can do a central simple ellipse. You can do a Grisotti flap, or you can do a Weiss pattern and remove the nipple. And that will give you a nice shaped breast. It's much better than having a mastectomy. And we'll have some videos about those if we have time in the next 5 minutes. Now, multifocal, multicentric breast cancer, we're not going to go through this. This is another 20, 30-minute talk. I do conserve some ladies with multifocal, multicentric disease. This is our paper from 2 years ago, giving our thoughts about multifocal, multicentric breast cancer. And we've done another study looking at the global variation of conserving multifocal, multicentric breast cancer. And you find that nearly 2/3 of people believe that this is conservable in certain patients. The most important is to plan, because if you fail to plan, then you're planning to fail. And there's lots of factors. You're not operating on a breast. There is patient, there's a tumor, and there is the breast itself. And of course, there is us, the surgeons. Not everybody will be able to do everything. So we need to choose our battles. The patient factors, common sense is not always common. Things like age, comorbidities, habits, especially smoking and drinking, and profession are very important when you choose the patient and the operation. And you need to manage expectations, because some ladies think that they're having aesthetic surgery. They are not. They're having cancer operations. Even if you're doing it in a reduction, it's a cancer reduction. It's not cosmetic surgery. And the breast, they come in different sizes and shapes. There's a small breast, there's a very large breast, there's ptotic breast, skin quality is important, previous radiotherapy, patient wishes, and the contralateral breasts. And always think about biology, because if you don't understand biology, you should not be doing breast surgery. So site in the breast, biology, and other treatments. Just a couple of small examples. So this is a lady with a 3 centimeter tumor, luminal A, node negative, so she needs surgery first. Will your surgery be different if she's non-smoker, fit and healthy? Will it be different if she's a smoker, fit and healthy? And will you consider something else if she's heavy smoker, uncontrolled diabetic on steroids? So it's the same breast. It's a different patient. It's a different operation. For the first fit and healthy, I'll do a mammoplasty Weiss pattern. For the second, I'll de-escalate a bit. I'll go for a lateral mammoplasty. For the third, she is high risk. Things will fall apart. You'll go for a simple wide local excision. And what you can do for the lady on the left-hand side is completely different than what you can do on the lady on the right-hand side. So this is a lady that if she has a 3 centimeter triple negative breast cancer, will you do things different if it was 3 centimeters of microcalcification with DCIS in the upper outer quadrant, or 3 centimeters of microcalcification with DCIS centrally? So this is an actual lady that had a 3 centimeter triple negative breast cancer. She had her chemotherapy, and this is her post-op results, because she already had complete response. I've done only the clip out, and you can see symmetry. But if you started with the surgery, then you will not achieve that. If she had microcalcifications with DCIS in the upper outer quadrant, it's either a mastectomy with implant, or you can do wide local excision with chest wall perforator flap to fill that, and I'll show you a little video about that. But if the microcalcifications is central, then she needs a mastectomy, maybe with an implant. While this lady, if she had multifocal multicentric disease, do you really want to do a mastectomy on one side and leave her with 1.5 kilos on the other side of breast tissue? So this lady had a multicentric disease on the left side. She had bilateral reductions. So lots of things to think about. You need to balance lots of factors. Always remember your oncology. If there's indication for chemotherapy up front, just give it up front. And try to decrease your complications by choosing your patients, improve aesthetic outcomes, and your aim is to do less mastectomies for patients that want to keep the breast. You'd want to avoid those results. Scar placement, we're not going to talk much about that. All what I'm going to say is that always plan your mastectomy when you do your wide local excision, because 3% of your patients that have mastectomy will need wide local excision will need a mastectomy at the end. So always remember that the majority of the patients will need a simple operation. 70% of patients will need a simple wide local excision. Don't complicate things. And always manage expectations. So for level 1 oncoplastic surgery, we're talking about dual plane mobilization. This is from the Chris Nakloff famous paper, to be able to close a defect. And when you look for the scars, I usually don't cut on the breast. I usually do a periareolar incision, maybe a little lateral extension like a wine glass, sometimes inframammary incision or lateral incisions. And if there is a bit of asymmetry between patients, sometimes you can do a little crescent to improve those asymmetry. This is a lady that had wide local excision, and unfortunately there was large area of DCIS unexpected. So because I planned my surgery, I've done an inferior inframammary fold incision, I managed to do a mastectomy as an implant-based reconstruction. If the cut was on the breast, then you will not get this result. But remember, many ladies, all what they need is just a cut on the breast, take the tumor out. If they need a completion mastectomy, they don't want reconstruction. A couple of videos, and here if you need me to stop, you tell me when to stop. Do you want to play the first video? You need to play it from your side. That's great. So central wide local excision is a simple thing to do. There's central tumors. What you do is you need to cut on top, cut below, and just go down to the fascia. So you do your cancer excision first. It's the first thing is you do your cancer surgery. You go down to fascia. And once you do your cancer surgery, you always leave the metal clips for the radiation oncologist so that they'll thank you when they do the radiotherapy. And after you do the cancer excision, it's very important not to just simply close the cavity, because that will flatten the breast. It will not look good. You need to mobilize the whole breast a bit in dual plane and close it in dual plane. And I usually close the gland in those patients if the gland is dense enough to take the sutures. If it's very fatty tissue, I wouldn't put the suture there, and then I'll close in 2 layers. I always sit the patient up a bit on table if there is any doubts about the ptosis, because this is a young lady in her early 30s, and the last thing you want is to have 2 different looking breasts. So let's see. Oh, sorry for that. So we'll go for the next video. Do you want to see? No, sorry, yeah, that's great. Sorry, we missed the last bit of the first video. So the second video is a Grisotti flap. It's a simple dermoglandular flap. Those are little videos that might be of importance not only to surgeons, also to oncologists, especially when they do their radiotherapy. Sometimes to pathologists to see how we do our excision. So you keep the bit of a dermoglandular flap, this is a central tumor, then you do your oncology excision. The same principles, you go down to fascia, you do your excision, you do your x-ray to check that all is okay. Then the flap is a simple flap. It's a dermoglandular flap. You just need to mobilize the breast tissue. You need to go down towards the chest wall, because the blood supply will come from the lateral intercostal artery perforators, and you need to release things for things to close. For the surgeons here, it's very important not to close under tension, because that will not look at the end. It will not look good. So always mobilize as much as you need to mobilize. Put some clips. Check that it looks okay on closure and there's no tension at all before you start closing. Always do your hemostasis, and always put the clips for the radiation oncologist for them to do the radiotherapy for you.
2 minutes, Dr. Yazan.
That's great. Then we'll skip this. We'll do a round block. Yeah, do you want to start the video? And we'll cut it halfway through. The round block, very simple also. You just need to deepithelize the skin. And I usually use scissors to deepithelize the skin. And then when you open the planes, you need to open you have done that deepithelization, so you need to leave so small part of that deepithelized skin for you to be able to retract on and to be able to suture on. And then after you do this bit, then you think about oncology. You go on your oncology planes, you do your excision, but always when you go on the oncology plane, before you do your excision, you mobilize laterally and medially a bit more to be able to close the defect. Always when you deliver the wire, you put an artery clip on that, and you deliver the wire with a controlled manner, otherwise the wire can move and you lose your tumor. You go down to fascia. I always go superior and flip the specimen down, and then when you excise that area, you always mobilize things medially and laterally to close the defect, and then most of the time I try to put the marking stitches for the pathologist when the specimen is still in the breast, otherwise you'll get the wrong marks. And I'm going to skip half of that. The closure will be in 2 layers, and I'll close the gland. And there's quite a few other videos, so we're going to skip the lateral mammoplasty. It's a simple operation also. We're not going to go through that. We'll just go through a little. Also, there's a nice omega, but because of time, we'll just go on only for the Weiss pattern for now. And the Weiss pattern, where you do the surgery, is not in theater. Where you do the surgery is before theater, when you plan the patient, because you cannot do any of this in theater when the patient is lying down, especially with a bigger cut breast. And remember, you can do a superior medial pedicle and remove the whole lower half of the breast. You can take 5, 6, 10 centimeters out of a big breast. Sometimes you take 1 kilo plus of breasts. It's not unusual in Scotland to have a K-cup breasts. And when you do an inferior pedicle, you can take the whole upper half of the breast. And that's where you do most of your surgery. I always tell my trainees, if you're not there for the marking, then you'll never be able to do that operation. The excision is very simple. Yes, it takes about 1.5 hours each side excision, and another 1.5 hours for the closure, because the closure takes long time. You can see the bracketing wires, because it's a larger tumor. The epithelize sometimes with the skin, and sometimes with the scissors, and we'll just show the lower half is all being taken off. And there's a video that is only 20 seconds.
Absolutely.
So this is, the whole lower half will come off. Sorry for that, it's because of time. We cannot show everything. And the last thing, which is the new kid on the block, is mainly the chest wall perforators. I don't know if this video will work. No. Can you play the video from your side? It's not working on this side. It's a 20-second video just to show you one little thing about chest wall perforators, if it works. So chest wall perforators is a simple operation. It's not difficult to do. You just have to know where your vessel is, and you can dissect half of the chest wall and put it in to reconstruct the flap. I think the video is not working from there, so that should be okay. Then, thank you for putting up with me for the past 20-25 minutes, and thank you.
Thank you very much, Dr. Yazan, for the nice presentation. And now it's my pleasure to introduce my colleague and friend, Dr. Sameh Hashim, who is a senior radiation oncologist at Al-Musa Specialist Hospital. He's the head of radiotherapy services. He will talk to us today about updates in radiotherapy for breast cancer. Enjoy the difference, and I'm sure you will enjoy the great talk.
Thank you so much, Mr. Chairman. Assalamu alaikum. So, in general, a couple slides to just explain exactly what we're talking about and what's radiation, what we're doing. So in general, this is the target volume where we give radiotherapy. Usually we treat the whole breast, and we add on top of that the axillary lymph nodes, level 1 and 2, sometimes the internal memory lymph nodes, and other than that we add the infraclav or the level 3 axillary lymph node or the supraclav. So that will be given in 2 different separate fields. Those will be, the lower one will be targeted in 2 tangent fields and the upper one in a direct field. So radiotherapy is delivered in 2 different regimens. The conventional regimen, which is the usual regimen that we give at least 25 treatments. So it can be given in different ways. It's going to be like more than 5 weeks. And the other regimens is the hypofractionated regimens, meaning giving lesser dose of radiation, lesser period of radiation. This is called the moderate hypofractionation, where instead of giving 5 weeks of treatment, we go to 3 weeks of treatment. And we have now what we call the ultra hypofractionation, where we give radiotherapy in 5 days. So we moved from 25 treatments, 5 weeks, into 1 week, 5 days. So add to that, we boost the tumor bed. The booster dose, we look at the tumor bed itself, where the disease was, and we include the scar where it was resected with the margin. This is what we call a boost. And the boost can be delivered in like 4 treatments, 5 treatments, on top of the conventional field. So the length of the breast treatment moved from 5 to 6 weeks to 5 treatments. So we always know that it's safe and efficacy of breast conservative, meaning doing breast conserving surgery followed by radiation. It was confirmed in phase 3 randomized trials and gave an overall survival comparable to mastectomies. Add to that, after mastectomy as well, there's a good also outcome from radiotherapy in local relapse, where it's less compared in patients with local regional recurrence, and in the first recurrence also giving radiotherapy would add a benefit over mastectomy indicated cases, and as well as breast cancer mortality. So what really happened? What are the updates? What really is going? So we know that the radiotherapy is effective in terms of conventional way. So when conventional radiotherapy started in 1960, afterwards we had the first hypofractionation treatment in 1970, where they give like randomly, not evidence-based, different type of short courses of radiotherapy. Those resulted in very extensive late toxicities. And from here, there was like in the 70s and 80s, increase in radiation-induced injuries in those patients in UK. And some over a period of 10 years, and some of the patients, they reported like about 40% having complication like brachial plexopathy. So afterwards, the UK, there was a women group called RAGE that really brought up this issue, and that mandated the National Health System in UK in order to ask the Royal College of Radiology to conduct a study or a follow-up or investigation to see what is the optimal hypofractionated or short course of radiation that really would prevent having those complications. And here comes the genesis actually of the START A and START B trial. The START A trial and START B trial is a very comprehensive, organized study that looked into different regimens of radiation, comparing that to the conventional fractionation regimen. So they compared the 25 treatments over 13 treatments in different scenarios, and the START B as well did compare the 50 grays and 25 over 40. So they reported very excellent outcome in local control. So the shorter radiotherapy is comparable to the longer radiotherapy in terms of disease control. And people say that hypofractionation of breast cancer is the patient advocacy achievement. That's true, because without that group of RAGE patient, nobody would go and tackle the shorter period of radiotherapy. So the breast hyperfractionation started also back then in Canada, where they conducted several studies till the clinical oncology group. They developed a protocol 42.5 degrees 16 fraction, and that also was in a very clinical organized trial, randomized, where they reported data of 3 years, 5 years, and 10 years, and with all the, they have a local good control data and the cosmetic outcome as well. So because of the good outcome and the result, it was in the ASTRO, Radiation Oncology, American Association for Radiation Oncology, they adopted the radiotherapy short regimen, okay, for patients who more than 50 years, early stage, did not receive chemotherapy. But in 2018, this recommendation also included the UK recommendation, 40 grays and 15 versus the 25 and 42 and 55 and 16 fraction. But they generalized the inclusion criteria to have any age, any stage with any chemotherapy regimen. So, but what's really interesting is those patients who had nodal disease. So do I give radiotherapy with short period of time with hypofractionation to those who had nodal disease? So this is a report of all 3 STAR trials. They looked into that case of patients, and they reported that adjuvant hypofractionation after surgery is very safe in long-term outcome. That was confirmed again in a Canadian study that compared the hypofractionation regimen in the UK and the Canadian to conventional treatment, and they reported that it's really safe and efficacious. And in the Italian study as well in 2022, also they reported that there's no toxicity, there's no grade 3 acute skin toxicity at early stage. So it's safe even to give radiotherapy to in a very hypofractionated way over 15 treatments for those who have nodal disease. That's good. But here come the UK study that reported 5 treatments only. And that was in 2022, where they compared the UK hypofractionated regimen to 2 different short course radiotherapy regimens, 27 grays and 5 treatments, as well as 26 grays, 5 treatments. And they had that, and most of the patients did, not most of the patients, 25% of the patients get a tumor boost. And they followed the patient for 71.5 months, over 6 years, and they found that the 26 grays and 5 fraction had better result compared to the 40 grays in 15 fraction and to the other regimen. So, and we look here at the in-breast recurrence, it was less in the 26 grays and 5 fraction. And because at the same time we had the COVID pandemic, the recommendation was to go for shorter radiotherapy regimens for those who had no negative tumor and do not require any radiotherapy boost. So, and again, the use of the hypofractionation in 5 regimen went from 0.2% to 60% utilization of those patients. So it's very good achievement that we're now starting to shorten the period of radiotherapy. But again, we're still interested in the lymph nodes of those who received lymph node irradiation. And the Fast Forward trial reported just recently in 2022 the nodal sub-study of their groups. They collected all the patients who received radiotherapy to the nodal area with the 5 treatment courses and reported the result. And the result was very comparable to the moderate hypofractionation regimen, and it seems to be that the arm lymphedema and complication as well as the swelling of the hand is less compared to the hypofractionation. So it's really safe now to give radiotherapy for patients with short period of time with even lymph node involvement. This is a detail also about the outcome of those patients and reported data. And we can see that it's comparable and have the same outcome results. So when we go to the major international guidelines right now, what they recommend. So in the ASTRO and ESTRO and Royal College of Radiology and the NCCN guidelines, they all recommend the moderate hypofractionation regimen for patients with whole breast radiotherapy after breast conservation, for breasts who had mastectomy without construction, and for those who had mastectomy with construction, and even for those who have lymph node involvement to give the moderate hypofractionation. But Still, the 50 grays in 25 fraction, the conventional, is not used anymore. So we're not using this regimen anymore. We're keeping it for special situation where we have like giving concomitant chemotherapy or patient has special comorbidities. So no one is using any conventional dose given the treatment of breast cancer in any of those guidelines. Again, only the UK and the European guidelines reported the use of short 5 treatment recommendation in whole breast radiotherapy and chest wall irradiation, and only the UK did report using this regimen in those who have construction breast surgery. And again, there's another hypofractionated regimen that's been recommended for those who have lymph node involvement in the Royal College group. So still, the UK actually is recommending 5 treatments in every scenario. It's safe, it's been shown that it can be done, but still, it's missing the expertise, the recommendation. You cannot really do this type of treatment without have a good machine with respiratory gating. And since this dose is like a stereotactic dose, 5.2 gray per fraction, I think more measures of controlling the breathing pattern of the patient need to be taken into consideration. So we will not really expose any normal tissue to that high dose. So there's another also regimen from the old FAST pilot, which gives 28.5 grays in 5 fractions over 5 weeks. Only 1 fraction per week was assigned to patients with significant comorbidities and patients who cannot really make it on a daily basis for radiotherapy. And the other thing, should I really boost or not to boost? Is it important when I'm using a very short course of radiotherapy? Should I give a booster dose or not? So again, the booster dose, as I said, this is tumor bed with an additional dose after giving radiotherapy to the breast. And there are indications to boost those diseases for patients less than 50 years and those who are from 50 to 70 should have high-grade tumors, and those with positive margins. And criteria for omitting the boost is possible as well for patients who are more than 70 years, ER, PR, hormone receptor positive, low or intermediate courses, and widely negative margins. And the booster can be given also while giving the 5 treatments or while giving the breast treatment or after, called sequential or concomitant or simultaneous integrated boost. So the boost delivered clinically that in the study looked at the patient with negative margin, and they have 2 arms, given the conventional treatment with a boost, and they gave like no boost to the patient. It's well known, well known to patient that giving the boost would give benefit for those patients, especially those who are less than 40 years in age, with the added benefit of 17%. But when we go to hypofractionated regimen, adding in the boost, it's a little bit tricky. There comes the UK study here in 2018, when they give they boost sequentially and concomitantly with radiotherapy, and they have really good, excellent outcome compared to the cosmesis and the way the breast looks without really major complication. 84% have no change in the breast appearance in the boost that given sequentially, and for those who were given concomitantly with the boost in the 15 fraction, were about 88 and 83. And again, there's another study been reported recently, and those patients have been given hypofractionated 15 treatments. They also were given a boost concomitantly, and they have the same outcome. So going to the fast-forward trial, the one which recommended 5 treatments, here we only, 25% were given boost. Those who are less than 40 years of age with tumor who had lymphovascular invasion or grade 3, or those who have poor prognostic factors. So not all the patients are eligible for the boost while you're giving the shorter course of radiotherapy. So when you go to the recommendation, I would go with the study recommendation. So when you give conventional hypofractionated, moderate hypofractionation, you can give 16 grays 8 fraction either sequentially or 48 centigrade 15 or 54 concomitantly with radiotherapy. When you give the Canadian protocol, you still can give sequential boost, 12 grays or 14 grays in 6 or 7 fraction. And when you go to the hypofractionation, you can give 10 gray or 5 fraction or 16 gray 5 fraction. So we can also use the concomitant boost from the UK hypofractionation in the Canadian hypofractionation. But nobody knows if we can do concomitant boost for the ultra hypofractionation in 5 treatment. So it would be safe to give the 10 grays and 5 fraction following the 1-week treatment. And again, the inclusion criteria for the boost for the ultra and moderate hyperfractionation would differ from the age and depending on the presence of prognostic factors. So in conclusion, it's a moderate hypofractionation. With the Canadian or the UK protocol, it's now the standard of care. No one is using the 25 treatment anymore. So we go with this recommendation. Ultra hypofractionation, giving the treatment in a shorter period of time over 5 treatment is not anymore considered as experimental. That need to be included in the clinical practice. People need to include and think about it very seriously, since it really would help patients, especially in the pandemic situation. But as we said, and we're still in the hypofractionation, only I would recommend to give it in a sequential manner. So still we need longer follow-up for the fast forward to think about nodal disease. I'm not sure whether it's time now to step in and give the 5 short course in 5 treatments for those who have nodal disease. Thank you for your attention, and hopefully I did not really bore you with my lecture.
Thank you so much, Dr. Sameh, for the great presentation. I think it's time for the questions and answers. Dr. Muhammad will lead the discussion.
Thank you so much, Dr. Sameh, for the brief presentation. I think you gave us 5 minutes extra so we can put it on the discussion side. For the audience, you can check that there is a QR code on the back of the ID card for any questions. So you can submit your question electronically and we can have it here. We'll have a discussion. So we can kindly invite the speakers to the stage, please. Dr. Anur, Dr. Hamid, Dr. Yazan, Dr. Abdul Latif, and also Dr. Sameh, please. You can, yeah. So the floor is open for discussion, and as the moderators also, we have some discussion points for many of the presentation. It was a nice presentation. I will start with ladies first, as usual. So the question to the radiology, Dr. Noor Naimi. The question came as, how can we modify the international guidelines for breast cancer screening for average risk populations according to our population? We see patients younger than 26, less than 30-year-old ladies presenting with breast cancer as average risk. So do you recommend that we have to have our guidelines to the ACR or NCCN guidelines recommendation?
Thank you. And so far, the average age presented with the breast cancer is 46. This is our local experience. I'm sure there were a lot of studies tackling this point. None recommended an early. They still recommend further exploration of this option, like an early detection younger than the age of 40 years old. I see a lot of young patients, 20 and between 20 and 30, and less than 40, but it's an observation. We need to collect a huge data to put such a risky recommendation. Now, the global recommendation is for the average risk. The average risk
are basically female, 40 years and above, till 70, with no symptoms. Whoever is younger than 40 with label of high risk, according to the risk assessment tools, they have a different pathway, which includes screening by MRI, alternating with mammogram, and other measures.
Thank you very much for the answer. The second question is for Dr. Hamid from the pathology point of view regarding the HER2. It was an evolving discussion nowadays regarding the HER2 enriched type of breast cancer. So the question comes now. We know that for +2 we have to have FISH or rich, whatever the further investigations to identify it. 3+ is already considered as positive. So the question comes for the ultra low group, 1+. Yeah, between 1+ and 0, you mentioned in your classification that there is an ultra low HER2 positive. Is there any further investigation that is coming in the horizon for this subgroup of patients or no?
Speaking about the guidelines that were published in 2018, until now you don't do anything addition for score 0 and score 1+. Score 0 require no further action. Score 1+ is by definition it is negative, and even for low HER2 expression, it is considered straightforward without need for in situ or any additional test. Thank you.
Now, a question from a surgeon to a radiation oncologist. So, boost or no boost? This is the question. And as surgeons, we hate boost. As radiation oncologists, you love boost. And we know that patients above the age of 50, there is no survival benefit. But if you look at the import study, the aesthetic assessment was done by oncologists, wasn't done by surgeons. So we always have a bit doubts about how accurate is that, because what we see in the patient is not exactly what you see, and that also the results from the boost that ruins our surgery comes months or years down the line. Why will you still boost patients above the age of 50 if there is no survival benefit at all? And yes, there might be 1 or 2% decrease in the recurrence rate, but that has lots of other issues in their quality of life, like pain, like aesthetics, like other issues.
Good question. Actually, this is need to be discussed with the patient. I present the data and we go over discussion, but in general, patient over 50, I wouldn't really offer it even. But if there is any concerns, because patients now come educated and they know their rights and they ask about the boost. So we need to discuss the benefit and the added benefit of the boost. But usually I don't recommend that. I wouldn't really go.
Great. So we have one question from the audience, from the organization committee also. Dr. Ahmed Antar is asking specifically for Dr. Noor again. And I guess this question is regarding the high-risk patients. So I read it as it is. What is your recommendation for breast cancer screening, mammogram versus MRI breast, for patients with BRCA1, BRCA2 mutation who refuse the prophylactic surgical options? So put them on high surveillance.
Yeah, now the guidelines, ACR, American Cancer Society, they are all toward alternating, like putting the patient in the short interval follow-up, alternating mammogram and MRI. The reason is, but definitely not below the age of 25. Most of the guidelines recommend 30, 35, but not less than 25. So it's basically alternating mammogram with MRI.
Yeah, thank you so much, Dr. Anwar. So any further question, even from the presenters, between each of us? Yeah, sure. Dr. Wabari. to whom also to Dr. Hamid.
Hamid, كيف الصحة? Do you have any comment on ultra low HER2 positive? We are participating in a clinical trial with the Destiny, and we are sending those with more than 0, less than 1 to some lab in Switzerland for checking. But I really don't know what they're doing. So can you comment on that?
Okay, let's first revise what we expect to happen. Okay, I'm saying let's revise what are the expectations now. Immunohistochemistry score 2 plus. For now, do in situ hybridization. If it is positive, this will be equivalent to 3 plus, and the patient is identifies as HER2 positive disease. For score 1-0, you stop there, he is not eligible for Herceptin. Now, the expectation in the future, what we are expecting, most of the published data believe that score 1 plus and score 2 plus, so score 1 plus without need for in situ hybridization, and score 2 plus with negative in situ hybridization will be defined as HER2 low breast expressing cancer, and they will be eligible for treatment. For the new treatment that is directed against low expressing protein. Now, the ultra low, most of the data believe they are unlikely to respond. And because under immunohistochemistry, there is very little, barely perceptible staining under the slide in less than 10% of the invasive cancer cells. Now, my understanding that this is not enough to call it. I think it will be watched again. I think that this will be observed, and we expect that additional data will come to see, because most of what is available now, that these people may or may not respond to treatment. Now, we have to understand that there could be inter-observer variability. What you are calling as 1 plus, others may call it 2 plus, and vice versa. So, following consistency and reproducibility, and following all these also results can be affected by the fixation, the ischemia time, the type of fixative used. So all these parameters can affect the result. In addition to that, the pathologist who is reading the slides. So this will need observation, and data should accumulate to help us.
My question is again to Dr. Hamid. First of all, thanks for this lecture. About the HER2 again. About the HER2 again. Do you advise to repeat? Do you advise to repeat the HER2 when the patient is low grade and ERPR positive and older age, if it is positive, if the result is positive? And the second question is, what about the equivocal positive patient with immunostaining and the FISH? Do you consider it positive? Do you convey the message to the clinician that it's positive because it involves a lot of medication that's expensive? Thank you.
Thank you for your question. I understood the second question, and I will answer it, and then we can discuss what you mean by the first question. For the second question, any equivocal result for HER2, which is immunohistochemistry 2 plus, should be repeated in exogen, or you should perform in situ hybridization in the core biopsy. If both immuno and in situ hybridization in core biopsy were negative, it must be repeated in the exogen specimen. In my practice, if I have a result that is equivocal for both immuno and in situ in the core biopsy, I arrange with the surgeon when there is excision or mastectomy, and I shout asking for the specimen to be delivered to me as soon as possible. I want to make sure that the fixation time and ischemia time are concordant with what we need according to the guidelines. Less than 1 hour for the ischemia time, less than between 6 and 30 and 72 hours fixation time. If we follow this, we expect that we will get a definite result in the excision. Now, for the first question, may you ask it again, please? Okay. It was not clear, the first question.
Because we are short of time also, and I think we had 2-hour session, so
if the patient is positive but low grade, ERPR positive, and probably older ages, do you repeat it automatically or you discuss it with the doctor?
If it is positive, you don't need to repeat it.
Shortly, Dr. Hamid, yeah. Yes or no? Yeah, go ahead.
Don't repeat it.
Thank you very much. So
unless,
I think...
Unless if you don't trust your pathologist.
Thank you so much. It's really discussion evoking points, but we are short of time. So thank you very much for all the presenters, and wish to see you in the next session, inshallah. Yeah.
Thank you, thank you. Please, I would like to invite all the speakers and moderators for appreciation session. Keep, please here. Dr. Zainab, please. ما رح ناخذ discussion، ما رح ناخذ بريك، رح نكمل. بدأنا مأخرين ساعة. دكتور عبد المطلب دندن. left. اوكي. دكتور محمد الدهيلب. دكتور محمد. دكتور إبراهيم العثيم. دكتور نور. دكتور حميد الجواد. دكتور عبد اللطيف شريف. دكتور سامح هاشم. دكتور يزن. and دكتور يزن مازنة. and دكتور حنان عبد الكريم.
دكتور أحمد عنتر.
اوكي. Okay, thank you. Now, for the sake of time, we'll go directly to the next session. I would like to invite Dr. Moderators, Dr. Nurallah and Dr. Ibrahim, who will stay with us as moderators. Dr. Abdel Nasser Nurallah, Chief of Oncology Center in Al Mania Hospital, Khobar, and Dr. Muhammad Ad-Duhaili.
Expect to have
keep close of the mic because it's we have some sort of echo on the whole. So yeah. Yeah. So the first presentation of the second session again with Dr. Yazan Masannat. So with no further delay, I would like to invite you again and just keep close of the mic, please. Thank you. We can share the presentation of Dr. Yazan.
Yeah, that's fine. I'll use this mic, that's fine. So if you want to open the presentation, that will be great. So this second talk is less visual, is more evidence-based. It's about axilla and how axillary management has evolved over the years. And I think and I believe that in the future, axillary clearance will be an operation of the past, very much like Halsted mastectomy. But how did this happen? So no need to do all those things. We've done it before, and the IBREST book and the disclosure. So we know that the axilla has been important in breast surgery for years, and since the 16th century, Ambroise Paré and Michael Cervantes has said that we need to do axillary node dissection for breast cancer that have positive axilla. And in the 18th century, Moore has said that we need to do axillary node dissection even for the axilla that are clinically negative. Then Halsted came and he put the science into the madness that was happening with the different types of mastectomy, and he said we need to do the mastectomy, we need to remove pec major, we need to remove pec minor, and he defined level 1, 2, and 3 axilla, how we do the axillary clearances. And then Patey came, and we still stopped removing the muscles, but we still are removing level 3 clearances with the Patey's mastectomy. First question, do we really need level 3 axillary node clearance? And if you look at the data, I think one of the most influential people that has changed breast surgery and breast cancer is this gentleman. So Fisher understood breast oncology way before we understood that. That's why he pioneered breast conservation. And that's an SAB B06. But one of his very, very well designed studies was the SABP B04 that looked at radical mastectomy, with clearance of course, versus total mastectomy, which is mainly without a clearance, and total mastectomy followed by irradiation. And guess what? For node positive and node negative disease, whatever they did to the axilla, that did not matter. There was no change in the disease-free survival or the overall survival. And if you look at the survival for the node negative ladies, you can see that the radical mastectomy, total mastectomy with irradiation, and total mastectomy had very similar curves, while the one with the node positive nodes, that the radical mastectomy and total mastectomy with irradiation also had very similar curves. So radiotherapy is good enough. We don't really need surgery in node positive disease. And with the advancement of treatments in breast cancer, axillary surgery is more of a staging operation. We need to get rid of those results. So with level 3 clearances, that's what you get. The comorbidities are horrendous and you cannot sort it out. So is there any need for a level 3 clearance? There was, from nearly 20 years ago, studies and meta-analysis that looked at level 2 and level 3 clearances, and there is really no much difference. Then in the 1990s, people started thinking, do we really need to take all the nodes? And before sentinel node biopsy, in Scotland, you had the 4-node sample, which is by Prof. Forrest from Edinburgh. And if you look at that study, the patients that had clearance and the patients that had axillary node sample did not have any difference in their survival, indicating that the axilla is not part of your treatment, it's part of your staging. In fact, the patients that had the clearances had slightly higher recurrence rate, mainly because they did not have the radiotherapy, because most of those patients had irradiation to the axilla if they were positive. Then the new kid on the block, which is not a new kid, has been there for more than 20 years, was the sentinel node biopsy. That's where the dilemmas all started. And you look at the Milan study, you look at the NSAP B32 and the Almanac, all had false negative less than 10%, which is acceptable for the staging operation, and identification rate of more than 95%, with a very low recurrence rate of around 1% with a median follow-up of 8 years. So for the clinically node-negative axilla, we can do sentinel node biopsy. But when we have a sentinel node biopsy, if it's negative, we know that we don't need to do anything more. What about if it's positive? In the past, we used to clear. And now, we're not clearing that much. Do we really need to clear all those positive axillas? We know that radiotherapy works. That's if we go to back to the history a few years before from Fisher, we know that in SABB4 that it works. So people start thinking, if it's a positive axilla, can we just irradiate the axilla? And that's the Amoros trial. That had shown in T1, T2 tumors, 1 to 2 positive nodes, if you give radiotherapy, if you do a clearance, it's similar outcomes. And then the Z11 came after that to show that we can even do nothing, and the outcome is similar, with a caveat that those patients had radiotherapy to the breast, and there was no standardization of their field, so many of them had radiotherapy to the axilla. And the next step after that is the Posnock trial, and we were part of the Posnock trial. It's T1, T2 tumors, sentinel node biopsy positive, even if they had mastectomies, do they need to have any further treatment or not? And we're still waiting for the outcome of that, but I suspect that will not show any difference. Now, what about the positive axilla? So those are all patients that had negative axilla, which is about 3/4 of our patients. What about the ones that present with positive axilla? In the past, we used to clear everybody. But now many of those patients that have positive axilla will need neoadjuvant chemotherapy. So you can downstage the disease. You'll know a bit more about the biology, especially for triple negative and HER2 positive disease. And you can extend your conservation. So we use chemotherapy as a surgical tool. You give the chemotherapy, downstage the tumor, take less out of the breast. And for neoadjuvant chemotherapy patients, initially, people started doing the sentinel node biopsy before the chemotherapy, and then we had all those discussions in the MDTs. What if they progress? Is the staging before chemotherapy still accurate after chemotherapy? What if they were positive and became negative? Is it accurate? And if you look at the NSABP 18 and looked at the axilla in that study, 89% of patients that had clinically not positive axilla had some sort of a clinical response, in about 75%, and 44%, nearly 50% of those patients had a pathological complete response. So do we really need to take all those nodes out? But that brings the question, how accurate is it to do a sentinel node biopsy after chemotherapy? Especially that you'll have fibrosis, you'll have fat necrosis, you'll have scarring. The lymphatic drainage might completely change sometimes after chemotherapy. Tissue handling and dissection is different for us as surgeons, and the response can be variable. Now, let's look at the identification rate. How accurate is sentinel node biopsy post-neoadjuvant chemotherapy for the patients that had negative axilla initially? So that's the Gania study, and the Gania study from France showed that about 95%, 94.6% identification rate with false negative rate under 10%. It's 9.4%. And another study from MD Anderson showed very similar results. And the lovely review by Monica Moreau in JAMA that looked at that, and that's in node negative disease, sentinel node biopsy is accurate. What about the node positive disease? And that's where the questions start. So in the node positive disease, so clinically node positive axilla, when you have chemotherapy, either they become negative or they stay positive. If they stay positive, we're still clearing them. If they are negative post-chemotherapy, what to do next? Is sentinel node biopsy accurate? We go back to the Gania study from France, and for the clinically the node positive disease that has responded, the identification rate went down to 80%, and false negative rate of 15%. That's quite high. And one of the key studies was the Sentina trial in 2013. It was a multi-arm trial, but if you would like to look at the third arm, arm C, patients that had positive axilla that became negative had sentinel node biopsy and dissection, and they looked at the detection rate was 80% only, with false negative rate of 14.2%. But listen to this, if you had one node positive, it was 24%, the false negative rate. When you go to 3 nodes, it's less than 10%, and that's where you start talking about the 3 nodes for post-neoadjuvant chemotherapy. The Z1071 showed a very similar result. Identification rate was much better. It's 92%, false negative of 12.6%. But if you have 3 or more nodes, it went below the 10%, which is what we expect. And there's a lovely meta-analysis by the Irish team published in 2018. And that's where all the guidelines that we use for sentinel node post-neoadjuvant chemotherapy. 13 studies, nearly 2,000 patients, 90% identification rate. But if you look at the sub-cohorts, if you have a dual technique, it's much better. Identification rate of 11%, false negative. While if you have 3 or more nodes, you have a false negative rate of less than 10%. That's why if you're doing sentinel node biopsy post-chemotherapy, you'll need to do a dual technique, and you need to get 3 or more nodes. Now, they concluded that it is safe in certain patients, but it did not take off. Not many people were using it still. And there is nothing to tell us that it has any impact on the disease-free or overall survival. We clipped the tumor bed, and people started thinking, why don't we clip that node? If it responds, then we know that the node is out. And this is one of the key studies by Henry Curer from the MD Anderson. This is where you first hear the name targeted axillary dissection. They clipped the node and they did the sentinel node biopsy. And in that paper, the false negative rate was if you do a targeted lymph node dissection, which is mainly taking the lymph gland that was positive out, the false negative rate is 4.2%. If you did sentinel node biopsy only, false negative rate is 10%. If you do a targeted dissection, and that's the key thing, targeted dissection is taking the targeted node and doing a dual sentinel node, then the false negative rate is 1.4%, which is even lower than the normal sentinel node. Studies started looking at different way of localizing those nodes to be able to do the targeted dissection. We're looking at tattooing, clipping the node with an ultrasound scan, wire clipping, and the new probes. And when you do a target dissection, you always need a dual tracer sentinel node biopsy. When I do my sentinel node biopsy, I usually use only technetium, but for the target dissection, I always use dual. So carbon tattooing is a cheap and cheerful thing, but it's not easy to do. You need your radiologist to find the node. They put some carbon there, and they identify the tract for you. And this is a paper by Hartmann from Germany. It's a combined paper between Germany and Sweden. And the identification rate were impressive, about 93% for something that is not expensive at all. And the targeted node is the same as the sentinel node, is only about 60%. So if you do a sentinel node on its own, you will lose the previously involved node in about 40%, which is a key number that you'll see repeatedly. The other way of doing it is doing an ultrasound scan. This is the ILENA study from Isabel Rubio and the team. I think she was in Madrid at that stage. 96% identification rate. The problem, you need to be very experienced. You're not looking for an abnormal node, you're looking for a clip. It's not easy to find that clip unless you're a very good radiologist or a clinician that does lots of ultrasound scans. And ultrasound scan wire localization is not easy. So in this small study of 30 patients, they managed to wire only 80% of the axilla. It's not easy to put a wire in the axilla. And the wire does move, so even the 80% that were wired, 70% was the identification rate. And the CENTA study had a bigger cohort of 500 patients, and they managed to find the node in only about 77%. But look at the same number, the sentinel node biopsy and the target lymph node were identical in only about 2/3 of the patients. So if you do only a sentinel node, there's a 1/3 chance that you might miss that node. So intraoperative ultrasound scan is good. Wire localization using ultrasound scan is not that great. What about the new techniques? The RISES study has published recently using the radioactive seeds, and they have excellent identification rate. And the MAG seed, there's small cohorts looking at that, and also they have 100% identification rate, because if you put the seed there, you will find it if you have the machine. And the corcondils is the same with a sentinel node biopsy, only about 65%. All the other new technologies are being currently used for the axillas. Some of them have license, some of them don't have license. So we can find the node, and we can stage the axilla. What does that mean? So if the node was clinically negative and radiologically negative post-chemo, and it is pathologically negative, that's good. But what if there is still residual disease? Now, if you look at follow-up study, this is the team from Milan, and when they look at the follow-up 10-year of 688 patients that were clinically node negative or node positive pre-chemo, and then they became all node negative after chemo, axillary failures in the ones that were node positive pre-chemo was 1.8%. Axillary failure in the ones that were node negative pre-chemo is 1.5%. So there is really not much difference. So we can potentially leave those nodes. But there's lots of studies that we're looking at that. And there are lots of questions. If we are doing a targeted dissection, how many nodes we need to take in total? Can we leave the axilla if it's negative, or do you need to treat it? And we're still, for the CN1 axillas, if they respond, we're doing target dissections. What about the CN2? Not everybody is comfortable with the CN2. And if the axilla is still positive on pathology, but it's negative on radiology, then the disease is low volume disease. Do we really need to go back and clear it, or can we just irradiate that? And we know radiotherapy works. And the two trials that are looking at that is AXANA, which is multi-center trial, run from Germany in Europe, but there's lots of centers across the world, and the ATNIC, and we're part of ATNIC, which is mainly a UK study, but I think there's some centers also in Australia and that. So in CN not patient, node biopsy is okay. If they're positive, clip the node. If they became negative, do a targeted dissection. But if they're still positive, please treat either with radiotherapy or with clearance. And if they're node negative, can we really omit surgery and further treatments? I think this is most likely, but we're waiting for the outcomes of the trials. There's some other questions, and that's the last slide. What about target dissection in node positive patients that we start with surgery? Some people are starting to clip those nodes, take them out, and do a sentinel node biopsy even before chemotherapy. Just do a target dissection for patients in the primary setting. Is this safe or not? Also, can we omit sentinel node biopsy completely in low-grade tumors? So we're accepting in the small trial that we can do a large volume excision of small grade ones that are ER positive and have low Ki67. But if we operate on those, we're still doing a sentinel node biopsy. Why are we accepting large volume excision if it's radiological excision without an axilla, but not accepting it for surgery? And can we omit sentinel node biopsy for mastectomy with patients with DCIS? The chance of finding invasive disease is not very high, and this is the sentinel node study by my friend Andreas Karakatsanis, who's injecting the magnetic tracer in the breast, doing the mastectomy, doing the reconstruction. If there is invasive disease, the mag trace stay in the axilla for a good few weeks. He'll go back and do a sentinel node biopsy later. And if we're looking at omitting surgery in excellent responders, and the paper from MD Anderson came only last week or the week before about excellent responders doing a biopsy of the tumor bed, and if there is no further disease, not to do any surgery. So if we're accepting to omit surgery in those excellent responders and we're looking at that, can we omit also auxiliary surgery? Thank you.
Thank you, Dr. Yazan, for the nice presentation and strict time.
Professor Naji Saghir, actually we don't need to introduce Naji Saghir. He's a well-known figure in Middle East and in the whole world when it comes to breast oncology. He's a professor of clinical medicine and head of hematology oncology division, director of breast cancer of excellence at American University of Beirut. He's well known to his activities, research papers, and also he's founding president of the Lebanese Society of Medical Oncology. And the most really distinguished work he did, he's the one who established Base of ASCO in Middle East. And so I like always to listen to Professor Naji Saghir. Naji, the floor is yours. Webinar is not, is virtual.
So can we get Dr. Naji? He will be presenting teleconferencing on a webinar. So if you can go live for the connection, please.
Do you hear me?
Yes, we hear you. Go ahead.
Oh, I can start?
Yes, go ahead.
Okay, let me just share my presentation. I have to do the sharing first. 1 second. Share screen. Okay. Host disabled screen sharing. Please let me share screen.
Can we allow share?
Please allow me to share. The screen tells me host disabled screen sharing. Could you please tell the technician to let me share the screen?
Just 1 second, Prof. We'll just fix the, yeah.
Okay.
Try now, Prof, that you can share, please.
Okay, my screen is shared.
Thank you.
Do you see it now? Is it shared?
Yes, Prof, it's shared and you can start, please. The floor is
Okay.
yours. Thank you.
All right, so we can start. Okay. It is my great pleasure really to talk to you today about expanding the role of immunotherapy in triple negative breast cancer. These are my disclosures. Okay, triple negative breast cancer. How can you remove that هذه السكرين اللي بتبين فوق؟ كيف بنشيلها هذه؟ Sorry. Sorry, okay, this is, all right. By definition, sorry, I just don't see part of my screen. Triple negative breast cancer, as you all know, is defined as ER negative, PR negative, HER2 negative. ASCO cap definitions less than 1%. Tumors are usually high grade, high proliferative index, and high mitotic counts. 10 to 15% of all breast cancers are triple negative. And nowadays, there's a lot of discussions about including the ER less than 10% as triple negative. We now have recommended that they could be enrolled in clinical trials, ER less than 10% as a triple negative. Some countries, like in France, for instance, less than 10% is considered ER negative. Now, the new thing also is that there is about 15% of triple negative tumors that are HER2 low, يعني 1 plus or 2 plus with fish negative. Usually the recent study about like 13% 1 plus and 3% 2 plus. And this is an important entity for response to antibody drug conjugates. TNBCs, as you know, they may occur as interval cancers, advanced stage at presentation, common aggressive clinical behavior. They have a worse prognosis, and they're more commonly seen in younger women, obese women, also African American women. They recur often within a few years from diagnosis, and they recur more in the lungs and the liver and CNS rather than in the bone. That's the difference with hormone receptor positive disease. And metastatics, up to 15% develop a brain metastasis. 15 to 20% of TNBCs have a BRCA mutation, and usually patients with the BRCA1 mutation, usually they have TNBC more than 90%, and often it is the basal subtype. Now, the clinical and molecular subtypes, I remind you, it is, as I say, 10 to 15% triple negative, and usually ER/PR negative and grade 3. Now, among the triple negative, we now have also molecular subtyping, and there is heterogeneity in them. You have the basal immune activated or basal immune suppressed, mesenchymal, and the luminal androgen receptor positive. And that has implications regarding therapy, and one of them is immunotherapy that we will talk about. Triple negative have immunogenic potentials. We have tumor antigens that are released by the fact that you have tumors that are growing and have different genetic material than the normal cells. We have high mutation rates. We have tumor infiltrating lymphocytes. And also when we give chemotherapy and radiation therapy, we also induce cell kill and release of tumor antigens. And also the PD-L1 expression is present on the immune cells, maybe on the tumor cells. And we have two ways of detecting that. That is important for the immune inactivation and activation that we will talk about later on. And PD-L1 may be also upregulated by chemotherapy. Microenvironment is important. In immunotherapy that we will talk about is inhibiting the binding of PD-1 to the ligands PD-L1 on the tumor cells. And immunotherapy also reactivates cytotoxic T cells. The major studies that I will go over, single agent, Keynote 119, the impassioned studies, Keynote 355, and we'll follow the iSpice 2, GEPAR, NERVO, impassion 522, and the NeoTrip study. These are the first studies that showed effectiveness of immuno as monotherapy in metastatic triple negative breast cancer. We had an overall response rate anyway between 5 to 21%. And there is a median progression-free survival of about 2 months. Those are very advanced, heavily pre-treated patients with PFS and OS variable, modest, but there is some activity. So when we look at the single agent activity in first line or second line, we see that we see more better effects in earlier lines, like with atezolizumab, response rates 26% versus 6.5 in second line. With the pembro also, you see more responses in earlier line, in first line than in second line. And also, this is seen like in the time from the start of treatment as well. The progression-free survival and the median duration of response from the start of starting treatment. So it's always better when we start in earlier lines. And then came the Keynote 119, which compared pembrolizumab to chemotherapy, which was investigator's choice, capecitabine, eribulin, gemcitabine, or vinorelbine. And those patients had metastatic disease, already had 1 or 2 lines of prior treatment, and they must have had anthracycline and or a taxane prior treatment. And they have performance status. The co-primary endpoints were overall survival with CPS scoring more than 10 or more, or CPS 1 or more, and the intent to treat population. We see here that in this study, we have seen an improvement of survival in patients who have more than 10 or more than 20 CPS scoring. So that study is important to go now for the next time, which is going to be Keynote 355. But before the results of Keynote 355, we had the impassioned 130 result. Here we have atezolizumab, which is an anti-PD-L1, atezolizumab with nab-paclitaxel versus nab-paclitaxel alone in patients with triple negative breast cancer. Okay, these are patients who were in first line. Okay, they had, in the curative setting early, adjuvant or neoadjuvant, they had prior, treatment, and they were stratified whether they had taxane or did not, liver metastasis or not, and stratified by the PD-L1 status. These patients were followed, and primary, important co-primary endpoint, intent to treat population, and also PD-L1 population, PFS, and overall survival. The baseline characteristics, they were equivalent. Okay, now here are the results. Overall response rate, meaning adding together CR and PR, partial response, and complete response, we see that we have up to 59% response rates in patients with PD-L1 positive, while it was 43% only in the nab-paclitaxel alone. And interesting, there was about 10% patients who had complete response. And the median duration of response was 8.5 months versus 5.5 months. And when we look at the progression-free survival, we see an improvement in the intent to treat population, but we see significantly improvement in PFS with a hazard ratio 0.62. We see the median PFS from 5 months went up to 7.5 months, and it had hazard ratio 0.62. So we have significant result in PD-L1 positive patients. And when they looked at the overall survival in the intent to benefit, however, in the also, which was a primary endpoint, overall survival in PD-L1, there was a significant separation of the curves with a hazard ratio 0.67. Median overall survival 17 months, 24 months. However, this with the pre-specified criteria that the study investigators put was not statistically significant, but it looks definitely clinically significant, and it is meaningful. So based on that, the atezolizumab with nab-paclitaxel was approved by the FDA, but it was an accelerated approval. Other guidelines also incorporated atezolizumab with nab-paclitaxel first-line immunotherapy treatment, triple-negative breast cancer metastatic. However, the FDA required the confirmatory trial, and that was the Impassion 131. And here, investigators had atezolizumab with paclitaxel, which is available everywhere. They wanted to do that with paclitaxel because nab-paclitaxel is not available everywhere, and they needed the confirmatory trial. This study was similar to the Impassion 130, but unfortunately it was negative. It was a negative study. It was not positive. We can see that PFS is similar, around 6 months, and overall survival also no significant difference, neither in the intent to treat population nor in the PD-L1 population. Overall survival is around 20 months, intent to treat, and 22 or 28 even in the paclitaxel group alone. So this was a negative study, and based on that, actually, Roche, as you know, decided to withdraw further development of atezo in metastatic breast cancer. However, the drug is still approved in Europe and in many countries. Then Keynote 355, Keynote 355, first-line metastatic triple-negative, compared pembro with chemo versus placebo with chemo. And here, the endpoints, progression-free survival and overall survival in patients with, and also CPS scoring more than 1 or CPS score more than 10, equal or more than 10. And it was in the primary endpoints that is important. PFS and PD-L1 positive more than 10 or more than 1. So we see that progression-free survival, we have an improvement in the median progression-free survival. However, the hazard ratio was borderline, not significant. But in the CPS score more than 1, hazard ratio 0.74, significant. And in the more than 10 was the most significant. Here you see hazard ratio 0.63, 3. The overall survival results were also significant in the CPS score of more than 10 and slightly, with more than 1. So the recommendation is that pembrolizumab with chemotherapy, and it could be paclitaxel, nab-paclitaxel, or carbogemcitabine, significant in patients with CPS score more than 10. And it was recommended now pembrolizumab plus immuno plus chemo, first-line triple-negative breast cancer. Now, how do we test for PD-L1? As you know, in the impassioned studies, the Ventana SP142, and 41% of patients had positivity, even if it's only on the immune cells, it was included there. 7% or just 2% were outside of the positivity of the immune cells. And in the CPS scoring, when Dr. Rugo, published this paper, trying to check for concordance, we can see that there is significant concordance, but however, there are patients who have SP142 positive and CPS score 22C3 negative, or SP negative score positive.
Professor Naji, we have 2 more minutes, please.
Okay. So what is recommended is doing either or as a companion test for Atezo and the CPS score companion test for Pembro. Concordance is not 100%. We do one according to the drug we want to use. However, there are centers who do both if affordable, provided the drugs are available. If one is positive, they would use it if the other one is negative. So that's the recommendation now for metastatic breast cancer. Now it is in all the guidelines. It's all the guidelines. Now for in the neoadjuvant setting, our aims at reducing tumor size and achieving a PCR. If we achieve a PCR, do we need more treatment? If there is a residual disease, do we need more surgery, radiation, or systemic treatment? I wanted to discuss that. If you tell me we don't have a lot of time, these are the studies that look at adding optimal treatment in the neoadjuvant setting. Important to remember carboplatin. We have many studies, CLGB, brightness, I-SPY 2, also Keynote 522 and Impassion 031 for the immuno. We see that adding carboplatin improves PCR in the breast and axilla. The GEPAR 6.2 also showed that in patients with triple-negative breast cancer, adding carboplatin is beneficial. In the brightness study, improving PCR and also improving 3-year event-free survival, carboplatin in the study. Immunotherapy, the I-SPY 2 showed that it does reduce the residual cancer burden when it's given as immunotherapy before surgery. These are the I-SPY 2 results I can go over. Now the Impassion 031 using Atezo, this study in the neoadjuvant setting showed improvement in PCR in patients who had PD-1 negative or positive. Both had an improvement, but it's more pronounced in patients who had PD-L1 positivity. Now, in the NeoTrip study, atezolizumab was used, but it was a negative study, and the results were not improved with atezo. However, that study used anthracycline after surgery. We don't do that anymore. We do anthracycline cyclo with paclitaxel carbo before surgery. And interestingly, last week there was a study also a few months ago that PCR actually in high TIL patients who have high tumor infiltrating lymphocytes is higher when you use atezolizumab. Keynote 522, this is the study that used pembrolizumab with carbopaclitaxel followed by doxorubicin or ribupirubicin with cyclophosphamide, pembro versus chemotherapy. On the same chemotherapy was used, and the patient continued pembro in the adjuvant setting. This study showed higher PCR rates and higher event-free survival rates when we add pembrolizumab in the neoadjuvant setting. It was a significant event-free survival at the last interim analysis, higher PCR rates and higher event-free survival rate, 84% versus 76%. Also, the overall survival at 3 years was significant. Now, the authors looked at event-free survival by PCR. Those who get a PCR have no difference, but those who did not have a PCR, significant difference. This is where probably the pembro could be used after surgery. But if the patient has a PCR, no residual disease, there's really no significant benefit by adding pembrolizumab in the adjuvant setting as well. Remember the toxicities, they may be very toxic. We really have to be very clear, discussing with the patients all the immunotherapy toxicities that could be chronic hypothyroid, hyperthyroid, adrenal insufficiency, especially if it happens in the neoadjuvant setting. You have to be very careful at the time of surgery. So we usually check our patients when we give them that all the time. Remember the CREATE X. If you have residual disease, you can use capecitabine. What should we use, pembro or should we use capecitabine? We don't know, but that is another option, especially if costs are a problem. Capecitabine is very cheap. I'm almost done. If you have BRCA1 mutation or BRCA2, these patients are also candidates for olaparib. There's a significant improvement in overall survival if they have residual disease after a neoadjuvant therapy. In conclusion, metastatic triple-negative breast cancer, first line, CPS score more than 10, pembro with chemotherapy. The atezo and nab-paclitaxel remain approved in many places if you do the SP142 and it is more than 1%. In early breast, all patients need carboplatin. I think most patients do need carboplatin, especially if there's a high disease load or if no complete response after the adriamycin cyclophosphamide phase. The standard ACT or TAC or nab-paclitaxel, you can invert it. With the immunotherapy, we're using the nab-pacli or pacli-carbo before AC. Now, do all patients need immunotherapy? Now I remind you, patients with T1 and 0 are not candidates. They should not be given. We don't have studies to show that they should be given immunotherapy before surgery. These are small tumors. You have to do surgery first and sentinel lymph node, as we heard. Now, T2, T3, and 1 and 3, yes, neoadjuvant therapy is recommended according to Keynote 522. Attention to benefit, toxicity, we really have to explain all that to the patient, financial toxicity to the patient and to society. We need additional biomarkers, and I think TILs are also important. Now, do all patients who receive pembro neoadjuvant should get it in the adjuvant setting? Obviously, yes, if there's no PCR. But if there is a PCR, we may not need it. There is a study ongoing, optimized. Patients who get a PCR, they will be randomized pembro or observation. That's an alliance study. Capecitabine for triple-negative breast cancer patients with residual disease, and olaparib for mutated BRCA high-risk patients with residual disease. And with that, I thank you for your kind attention.
Thank you very much, Professor Naji, for this comprehensive presentation about triple-negative The discussion will be at the end of Dr. Wabari. It's my pleasure to present my colleague. Yeah, the presentation, yeah. So can we share the presentation? Dr. Ahmed Al-Wabari is a well-known medical oncologist who is a hematologist and medical oncologist, Department of Hematology and Stem Cell Transplantation at King Fahd Specialist Hospital, Dammam. He's a fellow in breast oncology with an interest in breast cancer treatment, certified cancer researcher, graduated from King Faisal University from Dammam. So Dr. Ahmed Al-Wabari is well known in the Eastern Province for breast cancer cases. The floor is yours after you prepare your presentation, please, Dr. Wabari. You can breathe, the audience. Thank you.
Disconnect this. Disconnect this.
Pull up the slide, please. Well, thank you very much, Mohammed, for the introduction. Dr. Antar and Dr. Hanan, thanks for the invitation, and I congratulate you for the conference. So I have two talks, and it's really very difficult to listen to someone for 40 minutes, so I'm just trying to, I'll cut it short. So one of the interesting things in oncology is the new agents that we have, right? So now we have, is the voices all right? Yeah, okay, good. So I was tasked to talk about anti-HER2, the new and exciting landscape, and this is my disclosure. The outline of the talk would be a background, followed by talking about the HER2 in the first line and beyond, then brain metastasis, then what Hamid has mentioned or discussed, the HER2 low. So before we go into details, you know that the anti-HER2, one of the things, do we have a, oh, it doesn't work, okay. So the monoclonal antibodies like trastuzumab and pertuzumab work in outside the cell, extracellular domain. These TKI, lapatinib, neratinib, as well as tucatinib, they work inside the cell. And then we have the ADCs, TDM1 and TDXD, where I will talk about their mechanism of action. These are called antibody-drug conjugates. In breast cancer, we really are very proud of the work that has been done. If you notice, the first line, the median overall survival with the first line treatment is 57 months. Yeah. يمكن يزبط معنا. Yes, it does not work. Thank you very much. And the other lines, the later lines, so if you notice here on the column right there, you see that this is the overall survival. I'm sorry. The overall survival right here. So the first one is 57 months. So if you have a patient with metastatic HER2-positive breast cancer, you expect this patient to survive 57 months. Still does not work. It's very faint. Now, this based on really the old Cleopatra trial where 2 anti-HER2 were combined with chemotherapy, and it really showed a 15.7 months increase in survival. In fact, 8 years landmark, 37% of patients who have been enrolled on the clinical trial, 37% of patients are still alive. So you can imagine how effective the treatment is. So this is called the Cleopatra trial, which is trastuzumab, pertuzumab, and taxane. Now, it has not been challenged for a very long time, and this is any patient with HER2-positive breast cancer. This is still the first line of treatment. The second line is TDM1, and based on this clinical trial. So this is TDM1, again, is an antibody-derived conjugate. There is an M-tansine, which is chemotherapy, attached to trastuzumab, which is the Herceptin. And they were randomized to receive TDM1 versus capecitabine lapatinib in the second line. And that also improved survival and became really standard of care at the time. Now, can we improve on this? Remember that this is only the overall survival here is 4 months in the second line. It's 4 to 6 months. Can we improve on that? Dr. Hamid talked about the HER2, and I'm not going to get into the details of it. But trastuzumab deruxtecan is another antibody-drug conjugate. This time there is a higher antibody drug-to-antibody ratio. So in TDM1, 3 payload to 1 antibody. Here is 8 payload to 1 antibody. It's more potent. The deruxtecan is TOP1 inhibitor. It works similar to irinotecan for those who are familiar with colon cancer, but it's very, very toxic if it's given alone. So it's connected to or attached to antibody. And what happens, the trastuzumab binds to the HER2 receptors, and they get endocytosed. Inside the cells, they release the deruxtecan. And another thing happens is that the deruxtecan can permeate through the cell to a neighboring cell that has no HER2 expression. So it kills the tumor cell that presents or expresses HER2, and it kills the other cell that's called the bystander effect. And that's why it changes the microenvironment, and we'll come to the HER2 low later on. So this is the breast Destiny 001, where TDM, those patients exposed to TDM1 were again exposed to TDXD, and it really showed an excellent response. This is the waterfall. Behind the moderators, these are the patients who actually had complete response. So patients treated with first line and second line, and this is third line, and they had complete response, a median progression-free survival of 16 months, and overall survival was not reached at the time. So this is a very promising medication in the third line. So as we all know, once we have effective medication, we try to use it earlier. So now we bring it in the second line. So in Breast Destiny 03, it was compared directly to TDM1. Remember TDM1 that I said it was used as standard of care in the second line, and it produced 4 months overall survival. This is TDXD against TDM1 in the second line, immediately after Cleopatra, the big trial. Look at the progression-free survival hazard ratio of 0.28. Look at the difference between the two curves in the progression-free survival. So it's clearly better than TDM1 in the second line. And overall survival will be reported this year in San Antonio, which is next month. So the bottom line, this became really a standard of care in the second line. Better overall response rate, better progression-free survival, expected to have a better overall survival. Now, the problem with TDXD, it's a chemotherapy, right? So you have TDM1 is rather much tolerated than TDXD. TDXD causes nausea, vomiting, typical chemotherapy side effects, and pneumonitis. So TDM1 is notorious to cause interstitial lung disease and pneumonitis, And in fact, in the first trial, 6 patients died on TDM and on TDXD. So we really have to be very vigilant with this medication. And even the mechanism of pneumonitis is completely different than what we know in chemotherapy and in immune therapy. It's a direct alveolar injury. And this is the guideline of, so once you suspect interstitial lung disease, you need to halt the medication immediately and start steroid and escalate steroid as needed. So it's really very important to understand and to know patients treated with TDXD. In fact, we have 3 clinical trials in تخصصي with the TDXD. We don't include patients with baseline lung disease to start with. Okay, we just don't include them. Now, I'm just going to touch on other antibody drug conjugates. One of them is trastuzumab decarmazine. By the way, there are like 3 or 4 other antibody drug conjugates. This is compared to TDM1. I'm sorry, this is after TDM1. This is a third line. Progression-free survival is the primary endpoint, which is positive. So this is also, you expect this to be in the market in the future. On the other hand, the NAILA trial, this is TKI now. This is not antibody drug conjugates. Neratinib, capecitabine versus lipatinib, capecitabine, again in the second and third line, and it showed improvement in progression-free survival without improvement in overall survival. What was interesting about this clinical trial, it is the CNS activity. And I will talk about that later on. But the CNS activity in this specific trial was very interesting. You note there that those with CNS progression-free survival, neratinib, capecitabine did better than lipatinib, capecitabine. Finally, on this in the second line, a chemotherapy-free regimen. Abemaciclib, trastuzumab, fulvestrant. This is no chemotherapy compared to chemotherapy of choice with Herceptin alone. And the primary endpoint here is a progression-free survival. There is almost 3 months difference in progression-free survival. So for those patients who cannot tolerate chemotherapy, we still can get away with chemotherapy-free regimen, including abemaciclib with fulvestrant along with trastuzumab. So the current guidelines, the first line is still unchallenged. Cleopatra still is the first guideline, first line of treatment. Trastuzumab deruxtecan became the second treatment of choice or a preferred regimen over TDXD, and this is also reflected in the NCCN guidelines. You see that the TDM1 is still considered to be okay in the second line, but it's not the preferred regimen. Now, let's quickly move to the brain metastasis. So patients, the problem with HER2 positive is for those with early breast cancer, 12% of them will develop brain metastasis down the road with early. Those with metastatic disease, 50% of them will present with, at one point with brain metastasis. Now, the difference between brain metastasis in hormone positive and triple negative compared to HER2 positive, brain metastasis in HER2 positive is considered to be an indolent disease. So you may treat with radiation, and the patient will live for two years without progression. But the problem is when they usually present with multiple supra and infratentorial, and you give them whole brain radiation, and you may if they progress, then you're stuck. You can't do anything. And sometimes they present with only brain metastasis as the site of progression. So you have systemically controlled, and you have brain metastasis, and Dr. Hashim just gave them radiation, and what do we do next? So here, what we should do next. So catinib is a tyrosine kinase inhibitor that has changed really the thought process on brain metastasis management. So tucatinib with trastuzumab and capecitabine compared to trastuzumab and capecitabine. At the time, this was considered to be second-line accepted regimen as a second-line. It started as a phase 2 trial, but because of the impressive results, they increased the number and changed it into phase 3 clinical trial. The primary endpoint is progression-free survival, which was positive, 2 months improvement in progression-free survival, and around 4 or 5 months improvement in overall survival. But here is the impressive thing: patient with brain metastasis. So patient with brain metastasis, there was doubling of a progression-free survival in overall survival. And in fact, those with active brain metastasis, there is 10 months improvement with active brain metastasis. So you give them treatment, or they failed, or you don't give them treatment. They have active brain metastasis, and you give them this regimen. There is 10 months, almost 1 year improvement in overall survival. And just to put it in perspective, this is patients with active brain metastasis. The progression-free survival with lapatinib capecitabine at 1 year is 0. The regimen is 35%. So clearly, this is an effective treatment in brain metastasis and those who have active disease. Okay, so obviously that was reflected on overall survival. Now, remember that we said that TDXD is the second-line treatment that is considered to be the preferred second-line treatment. In the 03, breast 03, the trial that I did earlier, TDXD versus TDM1, some of the patients had brain metastases. So those treated with TDM1, this is their outcome with brain metastasis as far as progression-free survival. And this is the outcome of TDXD. The hazard ratio is 0.25. So TDXD is also effective in a brain metastasis. So where to place them, which one is the drug of choice, is considered to be if the patient has systemic disease, mainly, and some brain metastasis, TDXD. If it's more brain metastasis than systemic disease, then tucatinib combination. It reached really multiple trials of TDXD. The overall response rate in brain reached more than 70%. So it's really an effective treatment in brain metastasis. Summary of this part, that for active and large burden disease, tucatinib is the way to go. TDXD is superior to TDM1 in treating brain metastasis, and other combination or ADC also have some activity in brain metastasis. So now let's touch on HER2 low. This is during ASCO this year, this presentation yielded a very warm reception. In fact, I was whistling and people were shouting and standing ovation. So this is your second presentation, right? No, this is the same presentation. Yeah. Dr. Hamid presented the guidelines for HER2 positive and HER2 negative and HER2 low. So in the past, I'm just going to summarize this. In the past, there was HER2 positive and HER2 not positive, which is negative. We consider it to be negative, okay? So 0, 1, or 2 plus, that's FISH negative, considered to be negative. We don't treat it with anything. We just treat it with hormonal therapy or chemotherapy, but no anti-HER2. And 3 plus, or the equivocal to with FISH positive, we consider it to be positive, and we treat them with anti-HER2 treatment. Now, Dr. Hamid said that there are a group of patients who are called HER2 low, okay? HER2 low meaning they are not positive, but they are not negative. And in the past, as I said, we used to treat them without anti-HER2. But now, and by the way, they represent 50% of breast cancers, a huge number of patients. So the Destiny 004, breast 004, randomized patients with HER2 low, so +1 and +2 FISH negative, after receiving whatever lines of treatment, hormonal therapy and whatnot, and chemotherapy. So this is a third line treatment, okay? To receive physician choice of treatment, okay? It's fair game. So whatever the physician will treat, treatment arm, which is TDXD. And the primary endpoint is progression-free survival. They did stratify those patients based on the, +1 and +2, and interestingly also they stratified them based on whether they have hormone positive and hormone negative. So remember, some of these patients are triple negative, or considered to be triple negative in the past. صح Hamid? So, yeah, so hormone negative, HER2 +1, that's triple negative in the past. Not here, okay? So this is the result for the intention to treat analysis. All patients, progression-free survival, 4.7 months. Overall survival, 4.8 months. For hormone positive only, 6.4 versus 6.6. And for those we used to call them triple negative, 5.6 months progression-free survival, almost 10 months in overall survival. So this is really a game changer. It changes the pathology perspectives for reporting, and it changes our perspective for defining. So when I write my notes now, I write hormone positive, HER2 low. I don't write, or hormone negative, HER2 low. I don't, between brackets, triple negative. So really, we have to adjust to this as oncologists and as pathologists. And again, this is the treatment of choice. This is the response rate. These are patients with complete response, zero disease. Okay? So the bottom line, we have a paradigm shift in treatment. This is an exciting news. We have TDXD among others, okay? It's not just TDXD, but TDXD is coming like an avalanche in breast cancer, treating patients with hormone positive, triple negative, HER2 positive, extending survival in the second line and third line, and also changing the way we define or classify breast cancer. Thank you very much. So you want to go with the, can you put up the second presentation, please? Yeah. Okay. Yeah. All right.
But then we move to the launch part period, then we can come back to you. It's very
Oh.
interesting. We'll keep you here.
Fair enough.
After him, no, the second.
Well, this is what they told me after Dr.
Second talk.
All right. I disconnected this thing. All right, so let's move on to the second talk. And second talk, actually, I blame Antar for the issue because this is an overlap with Naji. Naji Saghir presented part of this, okay? So this is going to be quick. So I am going to talk about a new adjuvant treatment and what we have achieved. And this is more relevant, in fact, to the surgeons, okay? And I really wanted to talk to this so the surgeon can not you, Hanan, I know you know. Yeah. Especially the junior surgeons. Why are we doing neoadjuvant treatment for breast cancer? So this is the outline. We'll talk about introduction and PCR, which is pathologic complete response, and what it means, and what are the strategies, including Naji Saghir included part of his discussion, so we'll be quick. And then a new adjuvant approach with hormonal therapy for those whom we cannot do chemotherapy. And then finally, the impact of a new adjuvant treatment on adjuvant options. So
the general rule in breast cancer, the general rule, because we'll come to specific things, that neoadjuvant treatment based on NSABB, neoadjuvant and adjuvant treatment do not change outcomes in terms of progression-free survival or overall survival. This is the old, 20 years, 2008, very old information. And we know from the same trial that, the complete response is different based on histology. Hormone positive, they have 8% versus HER2 positive, triple negative, they can reach almost 80% these days. And it's important to do neoadjuvant treatment to avoid axillary lymph node dissection, as well as to avoid delay in high-risk patients. You want to treat them immediately with neoadjuvant treatment. So this is the NSABB B18, old trial, operation, chemotherapy, or chemotherapy operation, results right here. No difference, complete overlap, okay? But in the same trial, PCR changed the outcome. This is the progression-free survival, and this is overall survival. So PCR is better than no PCR, at least, clear. In fact, not the same trial, ABCT showed that patients who have a neoadjuvant treatment, Hanan, has higher local recurrence versus patient with versus distant metastasis that really didn't make any difference. But that was not because the chemotherapy does not work, because Hanan forgot to remove microcalcification. So what happens is a surgical technique. We need, this is an old, obviously, trial. The surgeons have adjusted their ways. The radiologists now are assisting with MRI and all. But this is 2007. So in the past, you give a neoadjuvant treatment, huge tumor, and now it's small, and we don't have MRIs and whatnot, and we forget some other satellite tumors. So local recurrence was higher. It didn't change the distance recurrence, but I think this is an old information. I think the local recurrence, we rarely see local recurrence now after surgery. Now, as physicians, we wanted to improve the outcomes with changing the treatment protocols. Dose intense, dose dense, giving more chemotherapy in short intervals to try to improve outcomes. And these are some of the trials. I couldn't fit them in one slide. The dose dense, and the outcome were all over the place. Some showed improvement in overall survival, some didn't. But the meta-analysis, which is of almost 40,000 patients, 26 randomized clinical trials, on what is the role of dose-dense chemotherapy, which is chemotherapy that, for instance, the AC, Q3 weeks, we give it every 2 weeks with support of GCSF. The bottom line, without going through the detail of it, it improved outcome. So in high-risk patients, especially for those with triple negative, the minimum you should do is dose-dense chemotherapy for them, the minimum. So if you give AC for every 3 weeks and docetaxel, this is not enough. This is old regimen. عفى عليه الزمن. It should not have been used in this day and age. So can we improve on PCR? Najis Saghir, Dr. Saghir, he presented some, first of all, the definition of PCR. We have been playing with this, total PCR, breast PCR. The bottom line now, PCR means no invasive disease. So we don't care about DCIS. DCIS there, that is still considered to be PCR. The German are more stringent, and they said total PCR, that there is no DCIS.